Right. Good morning, everybody. I think we've now started recording this meeting, and we are live to colleagues who are observing us and members of the public. So welcome. And particularly welcome to Governor colleagues who are observing us today. And also, just wanted to formally welcome. I know we've seen Tim in other meetings now already, but Tim, it's your first formal meeting as a board member, as an associate non-executive, so just wanted to welcome you. And also, I think this is Anne's first meeting in capacity of Chief Operating Officer, so I don't need to say welcome, Anne, but I just wanted to acknowledge that. I know you've been with us on many occasions before. Okay, so apologies for absence. Our medical director, Dr. Itai Matumbike, is absent and has sent us apologies, and Melanie Hall, also non-executive director. So we do have a register of interest, which is available for the public to view. And obviously we've all added to it, and I think we're in the process of updating it as well. But I just want to check if anyone's got any specific declarations for items on the agenda today, rather than any sort of update generally. So I'll take it that you haven't, unless you indicate in the usual way with your hand up using the facility. Okay, so minutes of our last meeting, which is the meeting of the 30th of March. So first of all, can I check for points of accuracy, please? If anyone's got any, can you again indicate so that we can just note them? But if, again, if you haven't got any suggestions of change, then I'll take it that those minutes are accurate and we can approve them. Are there any matters arising that we need to consider that aren't covered in our action sheet? Okay, no. Again, I'll take that as a no. So I've just got a little bit of background feedback. So can you just check if you're on mute, please? So we can make sure we've got our sound working well. Right, let's have a look at the action sheet then. So that's paper B. And I think we've got a risk that's been updated, which is risk D6. And the only, I think, perhaps question is we have got something which says 25th of May, TB 2339, Complaints Pals Concerns Report, inclusion of a breakdown of complaints by protected characteristics. I think we've got that, something in the report, certainly about ethnicity, haven't we, Julie or Linda? Chris?
So is that breakdown across the grades you're talking about?
No, so breakdown of complaints by protected characteristics. So it's the complaints report. And it says 25th of May. It's been discussed at the Complaints Review Committee. More work to be done. Just really to check when it will be going to quality and safety. Linda, will that be, when do you think that's going to be taken forward, just to give us an indication of when we'll conclude that?
Thank you, Chair. We are sending an update to Quality and Safety Committee next month. It's something that we've already made contact with our IG colleagues and our DTS colleagues on being able to set the information so that we can collect it in that manner. So the conversations are happening, but we will update Quality and Safety Committee with an aim of having that information ready for next board meeting. But certainly we will be providing an update next week.
Great, thank you very much, Linda. Okay, And there's something there about reviewing the content of the format of the report, but that's not due at the moment. So that's all the actions, I think, unless Richard, you've got anything else you wanted to comment on. Great, thank you. And we've got our forward plan, which is paper C, which really just shows the items that are planned on our agenda, many of which obviously are routine items or standard items that we consider. And have we got all of those on the program on the board today? So the only thing I'm just wondering, Richard, is whether we've got a board development program. Have I missed that, or is that?
You haven't, Christian. No, we've deferred that one to July simply because we're in the throes of doing our effectiveness review and thought it timely to include that after
Take that
the
into
effectiveness
account.
review has been concluded. Yeah.
Okay, lovely. Thank you very much. Any other comments on the forward plan before we move to our patient story? No, okay, thank you. All noted. So warm welcome to George Flanagan, who I think is already with us. Yes, I think I saw George, yes. And to introduce the story, I'm going to just ask Anne, in her capacity as Chief Operating Officer, to introduce the story and just welcome George. Over to you, Anne.
Thank you, Chair. So we are really fortunate to have George Flanagan with us this morning. He has a presentation that includes a patient story, and I have to say, in my new capacity of visiting different services and preparing for today, I think it just really reflects the diversity of services that we have, and even in such diverse services, there's a whole range of interventions we provide that really impact on not purely healthcare, but quality of life. And I think that really shines through. So George, welcome. I'd like to hand over to you for your presentation.
Thank you, Anne. Thank you everyone for having me. I would be doing myself a disservice and try and promote my own little nuanced service as well as doing this patient story. So my apologies if it comes across a bit self-promotory. So just to give you a little bit of background, I will just share. I'm going to put sound on as well, so there is a bit of sound coming from this. We've got full consent from the patient for all these videos, by the way. Our department, for those of you who don't know, is a slightly separate department off podiatry. We often get confused with community podiatry, but we're a podiatric foot and ankle service. So we do all foot and ankle surgery based out of Daintree. And, you know, I think I put this picture up on purpose from Nina Cashmore. So probably a lot of you were involved in maybe commissioning her for Daintree, but it almost, exactly I can say, promotes the locality of Daintree and how the local people are involved with it, but also just the ability for patients to actually have a really good experience at Daventry. I was saying to Emily the other day, we're a county-wide service, and I actually see some very complex patients come from north of the county, and often there's a little bit of trepidation in making the travel here, but once they're here, they find the experience really good, not just from my input, but from the experience being at Daintree overall. So I think it's often a hospital that doesn't always get the credit it necessarily deserves, because patients certainly have a good time here. So just to give you a little bit of background about our service, we're a small service, so we do foot and ankle surgery only. We're largely elective foot and ankle surgery, but over the last few years we've been moving into doing limb salvage surgery, which traditionally was undertaken by the acute sector largely because these patients were often unstable to be in a community setting. But just before COVID, and probably accelerated significantly by COVID, we've been taking on a lot more complex surgery that traditionally would have been undertaken within acute hospitals. And that's often utilising all the community services we have, such as IV therapy services for drugs, etc. So I'm just going to introduce Danny. And there's a video from Danny here. And Danny's been with us now in the service for around 2 years. And he's still with us because often these patients, even though they will have surgery with me, and I must say he mentions me a lot, and I've not picked this patient just because it saves me a lot. It just happens to be one that I know well. He's been with us a long time, and he highlights his experience with us, the impact on his life, as well as some areas, and I specifically asked this, where we could have made improvements or we might be able to close the loop, as I put it. So I'm just going to introduce Danny a little for you.
I had a motorcycle accident August the 3rd, 1966, when I had a severe injuries to both legs, but severe injury to my right heel. the footrest of the motorcycle, cut the heel off, and I spent the next 27 weeks in hospital in Northampton and Oxford.
So, in terms of Danny, though, what's happened is he mentioned, so he had an accident a long time ago, but traditionally these accidents weren't coped with very well. But he actually had quite innovative surgery, and I'll go on to mention this, where he's admitted into Oxford, and he ultimately had to have a flap onto his heel. I'll let him just tell you a little bit about that, and I'll just give you a bit of background about the flap, etc.
Whilst in the Churchill Hospital at Oxford, I had a flap done when they sewed my right foot to my left leg for a month, and I was in traction for 6 weeks, and then it was cut and sewn together, and it took about another 7 weeks before I could leave the hospital and put any pressure on the foot.
So I'm not going to, don't worry, there's not going to be anything particularly gruesome on these pictures either. I've left that out. But just to highlight some of the issues here. So you can see just here, there's a flap on a foot. Now it was quite innovative at the time, but because this gentleman unfortunately had basically the back of his heel cut off, it leaves a big hole. So you have to cover that hole with something, and that's normally skin. The problem is the skin on the bottom of your foot is really quite unique. It's very flexible. It moves when you walk on it. But if you have skin moved from somewhere else, which is in this case of his leg, it often means, for example, you'll grow hair out of the bottom of your heel because it's skin from another area of the body. So it's not the same kind of skin. So that ultimately means you will have problems for life, albeit at that point you've saved the leg. So I'm just going to go into what actually brought him into our service, because he'd had this a long time ago. So you think, well, what have we got to do with this? Well, Danny gives quite a good account here.
Over the years after the flap, I had several instances where I'd get an infection in the heel, and I sort of just kept taking different antibiotics, and we found that flucloxacillin was the best one to take. I did try several others, and it's been an ongoing problem right up until 2 years ago, come June the 10th, when I came here.
So what Danny underplays is his main problem has been pain for a long time, and he goes on to describe that he's had difficulty walking because he's in 24/7 pain. So he's been through pain management services acutely. He's been managed intermittently now for years with antibiotics in primary care, and then having acute admissions for antibiotics. And that's just been a perpetual cycle. It's been intractable, and unfortunately, this has just caused him not to be able to work, and had a significant impact on his life. The picture on the left is his heel when it flares. Now, just to orientate, because it's even hard for some of our trainees to orientate, this bit here is the back of his heel. So this is a hole at the back of his heel. And this hole would, every few weeks, blow out the back and release a lot of gunk, for want of a better clinical term, but it's a good clinical term, gunk out of the back. And this is what was causing his pain. So he's just going to describe a little bit the start of his story. I will say he goes on to congratulate me a little, and again, it's not me, me per se. This is the team, but he does use me, I think, because I was filming.
I was seeing Elaine Nichols, the podiatrist at Toaster, and she said, "We're not getting anywhere, Danny. I think I ought to refer you to the surgeons at Daventry." I first came and saw Mr. Riley, who said he could just do a little cut and a nick and a drain, and then Mr. Flanagan said, "I think we should send him for an MRI scan," and I'm very pleased that he did, because it showed an infection in the bone.
So we often think of infections as being acute things, and they happen and they go away. But with bone infection, so osteomyelitis, it can be sat in an area for years, and it will occasionally flare, depending, you might be immunosuppressed, you might feel unwell, and a bone infection will flare. So what we found out is this picture just on the left here is an MRI scan. This white area, so this is his heel bone. This white area is a deep infection within his heel bone that's been there for many years. And the problem is the flap on the bottom of his foot is inflexible. And so basically it builds hard skin and then gets a wound every now and then. And when it does get a wound, he's managed to pick up a bone infection that, when treated for a 1-week course of antibiotics, looks better, but the infection is actually still within the heel bone. And this is why for years he's had lots of pain. Now, prior to our service starting to do this kind of work, this gentleman would have carried on as is, because he presents to an acute service where they treat the infection for a week, it looks better, and then they go back out into the community. And then when we started picking up this work, we started looking at more complex reconstructive surgery that actually just isn't offered locally, even in the acute trust. And so we picked up this bone infection in his heel. His heel already looks quite dysmorphic, so it doesn't look normal, and that's because of the road traffic accident originally. So we move on to the surgery, which actually wouldn't have been available for us to do had we not applied for non-recurrent funding for a particular type of antibiotic, which I'll come on to in a minute. Again, because it's not something we traditionally did or were commissioned to do, but it's led on to us developing service level agreements with the Acute Trust for doing this kind of work.
The actual procedure was absolutely incredible. It was very short notice. Mr. Flanagan said as soon as he could get a team together, he'd do it, which he did. And it was all done in a day here in Daventry, which is absolutely excellent. Everything went absolutely brilliantly. The staff were excellent. Everything was explained to me. And so Mr. Flanagan talked to me all the way through the operation. And afterwards, he even pushed the bed back.
So traditionally, this surgery would only ever be undertaken locally within KGH or NGH if needed, and if at all, this kind of surgery just wasn't undertaken. They're often referred to Oxford because there's a bone infection centre at Oxford. It would usually require an inpatient stay for a long period of time with IV antibiotics. So these pictures here represent, and I won't go into it grossly, but basically I was able to remove part of his heel bone. So I opened up his heel, removed part of his heel bone, and the bits you see on the right-hand side, the black areas and those little dots, are impregnated antibiotics. So we never traditionally use these, as they can be quite expensive, but we, like I said, we applied for funding and got this, and we can use little pellets that we mix with antibiotics, and we use injectable paste, which turns into bone, and we injected that into his heel, and that eradicated the heel infection, because oral antibiotics can't always penetrate bone. And so in this instance, this patient would have needed a long-term stay, but we managed to able to do it as a day case procedure under local anaesthetic. So he's in and out within half a day. And we used the home IV therapies team to follow this up. But because of the antibiotics in the heel bone, it meant that antibiotics that usually would take 12 weeks, we could keep them on just for a week orally. So I'll just go on to his outcome.
Delighted. It's hard to describe really, but previously every time I walked, when I put my foot to the floor, it felt like it was being tapped with a hammer, and to have that pain gone and it stayed gone is absolutely incredible, and I'm really grateful.
And again, I think what he underplays is, although it's pain that he's largely focusing on, the alternative for Danny would have been to have a below-knee amputation, because traditionally in these cases where you have a recurrent and intractable infection that's causing pain, when there's not an option or a service in the area to reconstruct, the option is a below-knee amputation. And so we, at the moment at least, and he's still not out of the woods, which we'll come on to, we've stopped him from having that below-knee amputation, but more importantly, improved his quality of life because he's now able to walk. The pictures up here are his MRI once again, and those little white dots are where I've put antibiotics in. And there's no longer big white areas around it. The white dots are purely where the antibiotics are. And that's his heel at the top. Again, you can't orientate, but you can see now that all the skin is intact and there's no issues. And he's now 2 years on, well, 18 months on from the original surgery. So I specifically put my voice in here because I wanted to be sure that I've actually asked him where we could improve. And actually, he was very complimentary of the service and the trust overall, and particularly Daintree Hospital. But he had a little bit of feedback, which I'll come on to in a second. Danny, do you feel there's anything that we could improve upon that was negative about your experience with us at all?
No, I suppose the only disappointment would be that it does still flare up from time to time, which is understandable because, as I said to Mr. Flanagan, I'm basically walking about on the side of my left leg. I can't expect any more. But although it's a little bit sore at the moment, the pain is gone. And anybody that knows, 24-hour pain is not a good thing. So no, there's no negatives. It's all positive, and I'm just grateful. I just wish it had been done earlier.
So that thank you to Danny, because that concludes from Danny. But what and I've called it closing the loop, and it's only because it's a frustration of mine locally as well, and it's a commissioning decision, so it's not the trust. But because Danny is not diabetic, he doesn't get the rehabilitation care you would normally receive because there isn't commissioning in place for it. So what he means by niggles every now and then is the original problem is gone, but because he has a flap on his heel, he's always going to be at risk of further ulceration, because of the way he walks. And normally, if a patient is diabetic, there's services in place that can be monitored every few months, and any issues that arise can be quickly nipped in the bud before it gets to the point where I have to step in and do some more surgery like we did. Whereas because there isn't, he's not diabetic, he doesn't qualify for those services, and the services aren't in place. And so there is work to be done around closing that loop across the system, not just within our trust. And that's it from me. I will stop sharing.
Thank you. Thank you, George, and thank you to Danny for agreeing to have his story shared today. George, are you comfortable to take some questions, George? I'm sure board members would be interested to know a little bit more or have some observations. So Julia first, please, and if you could just explain your role so George knows who we are. Thank you.
Thanks, Krishni. Morning, George. I'm Julia Curtis, one of the non-execs. I've got a clinical background. I'm blown away. That's incredible. I'm just sitting here reflecting on the difference you've made to Danny's life, and don't underestimate the 24-hour pain issue. And you know, he's had years and years and years, and that's going to stay with me for a long time, I think, because you know, you're a service that people don't really know too much about, hence the reason to come and share and tell us more. But that is incredible. And I share your frustrations around, you know, if somebody is labelled with a particular condition, it opens doors. But what I'm really impressed with is how you took the initiative, you applied for funding, you took a risk, you know, you've done something incredible, and you're tenacious by the sounds of things, which is brilliant. And I'm really hopeful, you know, part of the wider system now, the whole point of the integrated care system is that these sort of stories can be heard and that we can change. You saved that gentleman, as you say, an amputation, masses of appointments at hospital, and, you know, his life has completely changed. So for you and the team, a huge thank you on our behalf.
Very kind. Thank you, Julia. And I agree. And it has led on, like I say, it has led on now for us to be picking up a lot of this work. So, for example, most of the non-major amputations, so a major amputation for NHS England is anything above your ankle bone. And actually, I think a lot of you would agree, if you had your foot taken off, it's not a minor amputation. But the majority of minor amputations or reconstructions actually now in the region are performed by my service here now, following on from that. So we've moved on a lot.
Thanks, George. There's definitely a few more to come, so just bear with us. So, Angela.
Yeah, thanks, George. I mean, a great example. I mean, it's so amazing the work you've done and the story itself, and the role of community services, I think, is just very, very evident. So thank you for that. I just wondered whether it would be worth yourself, Banu, liaising with Matt Metcalf as the Chief Medical Officer to just highlight the story, because I know Matt's obviously got an acute background, but I'm sure he would also be interested. And I just wonder if that might help influence of that commissioning perspective. And I think we should seize that through yourself and Banu. I really do, because I think he would be genuinely interested in this story as well, as an example. Thank you.
Thank you, Andrew. I know, I absolutely agree. And just in fact, Matt's actually sent me a letter recently about another patient that had sent a complimentary thing into him from the ICS. He sent me a letter, so he's kind of aware. Also, and very kindly, has placed me on the elective care board for the ICS. So I'm attending that anyway, and I'll probably raise it there, which we're going to be doing. So yeah, absolutely.
Great. That sounds like a really good opportunity to have that conversation, George, and as Angela says, I'm sure Matt would welcome that. Joe.
Thanks ever so much. Hello, George. I'm Joe. I'm a new associate non-exec director. So one of my personal obsessions is around prevention, and I'm afraid I'm going to carry on the vein of showering compliments on you and your service, George, because it's truly extraordinary, the work that you do. And I think we also need to remember that Danny isn't an individual. You know, he's part of a family, part of a group of friends. So actually the benefit of the work that you do will impact on a much bigger network. Angela's already picked up on the commissioning question, because I was going to make the point about how do we use these types of examples as a trust to demand more of the system? because we can see the benefits, we can see the improvements on Danny's life, but also being hard-nosed and economic about it, there is a benefit to the system financially through making timely interventions, which might cost a bit more, but the long-term benefits are significant. So how do we need to help you, particularly as we said, the commissioning is one angle, but the funding, your one-off funding, you know, that type of thing. Do we need to try and do something more to ensure that there's more availability of those one-off pots to give you almost the chance to prove a concept?
Yeah, I think in some ways, Joe, we're part way there. Joanne, sorry, we're part way there in that the other side of it is the diabetic patients, and actually the vast majority of patients who I do this kind of thing on now, because we are, is on diabetic patients, and there is some funding now. However, that's actually an issue at the moment, which I'm sure a few of you are aware, with NHSE funding. However, so there's an opportunity, and we're constantly auditing. We're in a research active department, and we work very closely with both KGH and NGH diabetes services. We are trying to promote those services and audit those outcomes, which will give us some justification for the non-diabetic patients. How we go about going down the route non-diabetic, I think the funding is traditionally placed within vascular surgery services in the acute sector, and I think it'd be very difficult for us to try and take some of that pot. Nigh impossible. So there's other routes of doing it. I think at the moment, I think the individual frustrations aren't for me personally, because I can probably perform these surgeries. It's actually the aftercare, and it's the follow-up care and the community care that needs the review. And I know we're looking at a system review around some of the diabetic foot pathways, but I think there's certainly a review on the non-diabetic foot, which is largely vascular, and people who have insensate feet for whatever reason. It almost needs to be a high risk review as opposed to a diabetic foot review. So I think there's certainly a review needed. I'm hopeful that being on the elective care board and having a bit of representation on that might help with that now, and that's going to be a new thing for me. So we'll see where that goes, I guess, and then maybe take it from there.
Okay, that's helpful. So I think in summary, the money's there, but it might just not be in the right place.
Possibly, yeah.
Okay. Thanks ever so much, George.
Thank you, Joe. Okay, a few more questions or comments. Banu next, please.
Thank you, George. Thank you very much. I'll share thanks along with Danny, and amazing piece of work. It just in some ways it shows kind of healthcare is so rewarding, and almost kind of that's the reason why a lot of us are in the jobs for these things. The couple of thoughts. One is that for like Joanne was pointing out, almost looking at kind of a research paper on or kind of on the benefits of if we were to prevent. It's not only the kind of the number of appointments, but a significant improvement in quality of life. So I mean, if we can look at that kind of work, that will be helpful. I think it might kind of make our case stronger. And the second, I just want to take the opportunities, like Julia was mentioning earlier, your kind of attitude to keep improving services is also seen in that clinical director role. So I'm grateful for you to be doing it, and I'm happy to be working together. Fantastic. Thank you.
Your support is very welcome. Thank you, Banu. Yeah, and you know, we as a trust, I think we're going to try as well. We've been speaking to the research team, utilize our mental health side of things. So we're going to look at a paper on the psychological impact of minor amputation as well, which will feed into that. So yeah, thank you, Banu.
Great, thank you. And just a little follow-up on that, George and Banu, on the sort of conversation we've been having, and I think there might be some more to come, but Angela's just commented in the text that perhaps there's an opportunity to have some patient stories presented at the board that you're going to be attending, George, and this could be one of them that sort of opens up the conversation. So that might be an opportunity as well.
Absolutely.
To really bring it to life, because actually it's the richness of this, as Joe said, you know, hearing the story, and it's the richness of the conversation that we're now having about, well, what does that mean, and how can we use that to learn to do things differently or better, and make some sustained improvement. Okay, there's Richard Wheeler, please, and then Julie.
Hi, George. I'm Richard Wheeler. I'm the Finance Director at the Trust. I mean, in relation to partly to Joe's question, I'm not sure whether the money is all there, and I think some of these one-off pots of money can cause us a problem if we don't have an exit strategy or a plan or continuation. So I'm more than happy to catch up outside George and just kind of understand where we are. But I think for the board to be aware, this has been publicised in a number of reports, that kind of one-off pump priming pots of money would, just create problems down the line, because they don't tend to get picked up by local commissioning, and then we create an expectation that can't be fulfilled. So there is a risk, and I think we need to, particularly in the climate we're in now, we need to be cognizant of that and have a clear approach on all of these areas. Thank you. But it's very enlightening, and I can see the great benefit, but we need to tie up all angles to this.
Thank you, Richard. No, I absolutely agree. Yeah, I'd take the opportunity to meet with you. Like I said, what we're trying to do, so we're currently just going through an SLA with Kettering to pick up the diabetic side of things. We already do it, really, but it's formalising it and getting funding for it. But there's an acknowledgement in there that some of those patients that are non-diabetic that fall within that service will come under that SLA anyway. So there's going to be some funding there to continue to do this work. It's just making it specific, because I think, as you say, it's fine getting some funding for another subset of the population. If we're using it on someone else and actually not highlighting this as a continuing issue, then it's never going to get solved. We just find bits from other places to fund it with. So yeah, I'd really appreciate time to meet with you.
Yeah, let's pick that up, because some of what you said just raises some more concerns with me. So let's pick that up outside.
Yeah.
It's a great opportunity just to explore that, I think. Julie.
Hi, George. I'm Julie Shepherd. You probably know, Chief Nurse for NHFT. But also my background is I was an orthopaedic nurse. I was really interested in this, seeing how things have moved forward. And I think for me, we're talking about elective care, but this type of case has an impact on admission avoidance and urgent care, doesn't it? Because actually there'll be repeated admissions for infections, for IVs and things like this. So I think it's something we need to consider as what is the impact on our urgent care pathways as well, because I think we should be looking at it from two avenues. And I think the other thing is, I sit on the ICB Quality Committee, and we're always looking for patient stories. And I actually think this would be quite a powerful one as well, because we have not just health sitting there, but we also have our social care, our local authority colleagues, and it has an impact on them as well. So I think it's thank you for sharing, and I might be in contact.
Thank you, Jo.
Yeah, another opportunity to share this, I think, would be great. I mean, as many, it starts the conversation, as we've said. Final comment from Linda.
Yeah, thank you very much, George. Certainly, when I listened to the presentation, what struck me was I was sort of ticking through our pride values, and I could absolutely see those coming across in the interaction, and actually with how Danny was really at the center of planning his care and actually improving his life. I think what was also important to me was at the end how you captured that feedback, that actually there's different ways of collecting feedback. And it's really important that where there is that established relationship with practitioners, it's not just giving someone a form. It is that conversation you had with him that was really key. So thank you very much to yourself and the team, because yeah, that's absolutely our pride values just coming across really strongly. Thank you.
Thank you, Linda. And there are some further, as you would expect, George, I think it's fair to say that I think everyone's been blown away by the presentation and hearing this story. And as everyone said, I think it just highlights the importance of having this conversation. And there's just something I keep kind of coming back to. The new world that we're in, we really need to be thinking about commissioning in a much more strategic way, because actually if we think about it in outcome terms, and if we actually think about the admission avoidance point that Julie's mentioned, the the sort of you know, all the different elements which have not only improved his life but also potentially avoided other interventions that might have been more costly. Actually, it sort of makes a case for itself, albeit, you know, always the detail I'm sure Richard would want to explore, but I do think these are the opportunities that in the way we commission, we need to influence you know, the way we commission and how we work with commissioners to make sure the opportunities for this are perhaps a little bit more flexible based on the outcome we can achieve, which actually is a tick, as Linda said, for a lot of different things, not least I wrote potentially life-changing experience for Danny. So George, thank you so much. It's been absolutely can I use the word fascinating, because I think for those of us who are non-clinical, actually even hearing you talk about the sort of intervention itself is actually incredible, you know, to think about what you've been doing, and then to hear Danny's story personally, but also your insights, absolutely fantastic. Thank you Anne, also for bringing the story to light. And I think the important action to take away, I mean, brilliant that you're going on the joining the elective board, but getting this story shared and sort of following it up so we can pick up on how we take the learning from it and you know, offer this opportunity potentially to other patients too would be fantastic. So thank you, George, and hope many of us will get to see you on our travels when we get to Daintree at some point. Thank you.
Thank you very much, everyone.
Okay, brilliant. Thank you. So we are now moving on to our risk section, section 8, which the first item of which is the Organisational Risk Register, paper D. So Chris, over to you.
Thank you, Krishni. The ORR has a summary of the changes considered through the Strategic Exec Board. We'll include the details of the changes to the ORR. One couple of things to highlight in there, I think, is that the data risk that we wanted to consider at the Integrated Assurance Board is going in July. That's because we focused with a timeliness in the previous Integrated Assurance Board on the finance issues, a deep dive for that. Also, we've implemented the productivity working group, which I think is important because the workforce is one of the biggest challenges in terms of both the finance and the workforce. And we've got quite an in-depth plan there, really, how we're looking to work with all of the directorates within the trust to manage the workforce and identify vacancies and reduce agency. The other key element is the strengthening of the board assurance, which we've discussed at the board, and we had an in-depth discussion at the Strategic Exec Board, and we've included within the papers the proposed BAF approach, a template that we're suggesting we use, and obviously that's been circulated for comment, and that will become potentially the templates we use, and we would then look within the Strategic Exec Board to complete that template and to link the major risks with the strategic objectives which sets out. We also, as we've reported, discussed the exec risk group, so actually time allocated to have a group within our Strategic Exec Board meeting that will allow us to look in depth at the risks which the board had supported. We've got the TOR of that taken forward, and then we've also highlighted the ICB allocating its risk to its committees, and one risk that's been raised in relation to children and young people, which will have a risk summit and support to their quality committee. In terms of the decision is to receive the ORR for assurance and then endorse the proposed BAF so that that can be completed and then brought back to the relevant committees and board in due course.
Thank you, Chris. So any comments on the paper first and foremost from colleagues? Julia.
Thanks, Krishni. Thank you, Chris. Just wanted 2 quick points. One is to really welcome the sort of continuous improvement approach towards our risk management and making it much clearer. And it's been a great journey, and really welcome that. I think it's going to really add value. So thank you for that. The other thing is just to add a little additional assurance to people who perhaps don't know the process around the different risks, that we do look at them and have the opportunity in the committees to look at some of these risks in detail. That are assigned to the committees. So, for example, Chris has talked about the data risk, which we will look at in our joint integrated assurance committee shortly. But just to say that in the quality and safety report from our committee that you'll see a bit later on, we actually had an angle on that around clinical data and the importance of that risk and looking at some of the mitigations. And again, so that's been under our microscope. So it all brings in an overall level of assurance that it's all being looked at in the round. So thanks. Just wanted to add that little additional angle. Thanks, Krishni.
Thank you, Julia, for sharing that insight. Really helpful. Thank you. Robin?
I was going to make much the same point really about the data risk in particular, because this one's been knocking around for a while, and as Julia said, it's everywhere really, and it does need that kind of integrated review. So just to say, really pleased that it's coming up for a deep dive in the July meeting, and I think it's very much welcome, and that should give us the kind of assurance that we require. So great.
Excellent. Thank you very much. Thank you very much, Robin. Let me just check. Tim.
Yeah, I was going to say on the proposed templates, I was thrilled to see that we're doing 6-month trend as well, because that's clearly a change, which is a big shift and good to see. Where I'm going to be heading is towards the severity matrix and just going into the detail of that, because I think at the moment I'd just like more assurance that actually some of these big risks are being accurately scored. But what I'm seeing, I really like. I just want to get the assurance around it.
Thank you, Tim, and I think that opportunity will increasingly come during the Integrated Assurance Committee discussions. Joanne.
Thank you. Tim's just flagged something in my mind, which is it's sort of linked to the risk D6, but there is another side to the partnership arena, which is the fragility of some of our partners, particularly the financial fragility. Could we gain some confidence that those types of issues will be picked up as part of that process?
Thank you, Joe. David, do you want to come in on that?
Yeah, can do. I think there's sort of 2 bits in there. Absolutely very aware of making sure we're supporting people and where we're going. So some of the actions and things we've already done have been about long-term contracts for organisations like voluntary and community sector, and shifting them from 1-year contracts to 5-year contracts to help with things like that, recognising as a public service organisation there's things we can do. So we constantly look at saying what's best for stability for the system and how can we make sure that happens. So I think we sort of build that in, but happy we'll have a look and think about how do we make that explicit and clear to everybody.
Okay, that's good. Thank you, David.
Thank you, Joe. Chris?
Yeah, just really to pick up on Tim's point, I suppose partly Julia's point as well. I think that's very much the severity matrix and the testing, the scoring. I think through the discussions we've had with the board, that's why we've instituted the exec risk management group. That allows us to have more discussion on some of these things with everybody checking and balancing. And that also allows us to build on the approach which Julia's describing, which we are all very much committed to, is that kind of quality improvement approach to how we take this forward.
Okay, thank you. So we've had I think there's been some really interesting assurance given about the approach we're taking and people welcoming the developments. Clearly, the opportunity to scrutinise some of these risks will come through the Integrated Assurance Committee, and I think that would be a great opportunity for non-executives to really test that sort of all the elements of a risk that we're looking at. So I think that'd be really helpful. Can we take the opportunity then to, obviously we've received the report, but endorse the templates because obviously that is the next stage in our journey of developing this. So I think colleagues got the opportunity to see that in advance of the board as well. So everyone happy to endorse those templates and the steps that are being taken to develop this. Great, thank you very much. So that's the ORR. We do have an opportunity for Anne just to give us any update that you want to, Anne, about sort of operational risks at the moment, COVID-19 system-wide, winter planning, with the permanence of winter.
Yes.
So Anne, over to you.
Thank you. And it does feel very odd talking winter when it's very sunny today, but I'll start with COVID-19. So COVID-19 is still present, but in a much lower levels in our community and not causing the impacts throughout sort of healthcare and social care. So we've been advised nationally that we've moved down to a level 2. And we're just working through what that exactly means, but it's a much more indication of business as usual and managing the huge amount of work that we've got just generally in particularly urgent and emergency care. We're still required to have a SPOC, which I think has been particularly beneficial during strike times, and also just coordinating us as an organisation. So we'll be working through that with the exec colleagues. Regarding the system-wide sort of position, we've been unseasonably in a really quite a challenged position across the system. We've fluctuated between an OPAL 3 and 4 for most of this month, which is worrying considering we are in the summer, but we are seeing a lot of pressure in our acute hospitals. In regards to winter planning, we are moving all of that work into the Urgent and Emergency Care Board, which is bringing us all together to focus on how we manage within the financial constraints to make the best pathways in and out of acute hospital for our populations. So that work has kicked off and is really looking at how we work on that increased demand and ensuring the flow is there as system partners. In relation to mental health and their a sort of acute area of work, I think that's also very much needs to be flagged, as we are still seeing a high demand on services, and particularly really working very hard at reducing outflows, which have been a consistent issue through the latter part of COVID. And we've started to make an impact on that, but it's been quite challenging. And so I think most of the urgent system has been very busy in the last month. We have an opportunity as a system to meet with NHS England to talk about that flow next week. So we will take that opportunity to share some of the real opportunities and some of the challenges that are faced, but that will all go into our Urgent and Emergency Care Board. I think that's about it. Krishni.
Thank you, Anne. Just good to get a feel of what it's like in across the system, really, and the challenges that colleagues are dealing with. And I know you will. I'm sure you will thank everybody for the efforts, because it's a continuous challenge, isn't it, operationally, and the pressure is significant. Any questions or comments before we move on to paper E, which is the final item in this section? No, okay, thank you. So we just note that update. So we have our report from the Integrated Assurance Committee, the first of this new financial year. Thank you to Judith, who stepped in to chair it for this first committee, although we do need to resolve the permanent chairing arrangements. But I know we have a paper, Judith, on paper E, but is there anything that you'd like to particularly highlight from that for the attention of the board?
Thanks, Krishni. Good morning, everybody. Just a few things very briefly. Just to start with, we did make some suggestions for changes to the terms of reference, because it's quite important to be very clear at the beginning of this new committee as to what the terms are. So that will come back for during the next meeting to be approved. As Chris has already alluded, and Julia also, the risk that we looked at was the finance risk, risk B8. And Richard gave the committee a very deep and understanding of the challenges and the work that is currently going on in relation to that specific risk, and he undertook to go following discussion to go and think about the way that the risk is currently worded, because the committee felt that there need to be some a clearer definition of where we are with the risk right now. And also we looked at the other risks within the risk register that were pertinent to the committee. Next time we're looking at B8, and really the assurance is the recognition by the committee of all the ongoing work that is going on with regards to risk management, not just for the BAF, but also the continual review of risks and assurance that the committee gained from that. So that's all I would have. I'm very happy to take any questions if there are.
Thank you, Judith. Scott.
Yeah, thank you, Kirsty. Thank you, Judith. My comment was really predominantly around actually the utilisation of the AAA reporting mechanism as we go forward. So I'd just like to say that, first of all, I think we can already see, both from this report and also from the one that Julia has prepared for the quality and safety that we'll see later on, we're just immediately getting much more insight from this, and having our eyes drawn as a board to the areas that we should be concerned about. So I'd like to thank you for the care that she's obviously put into producing the report, but also an observation, because at my substantive trust we actually use AAA, but we don't use the additional categories of risk and celebrating outstanding at the end of it, and I think that makes such a difference. Because it actually gives a much more sort of rounded perspective on the discussion that being taken, but also I would have said that one of my concerns about AAA is it only draws your attention to potentially to the negatives, and this does more than that. So congratulations to Richard and the others in the team that have added those additional elements on. So those were the comments I wanted to make, Krishni.
Thank you, Scott. I really welcome that as well, because it's always good to recognise what's been done really well, and to be that, to be really precise and clear about the risks that were considered, obviously very important in the context of the board's overall role and responsibility for risk. So thank you very much. Judith, back to you for any final comment.
Thank you, Krishni. Thanks, Scott. I totally agree with you. The only observation I would make is that the first time, having done it twice, the first time, as it were, once for this committee and once for performance, I do think there's a learning curve as to what you actually put in and what you leave out. So that's going to be an ongoing journey, and I look forward to working with the other chairs, perhaps, of committees to come up to have a consistent approach to this. But thank you.
Thank you very much, Judith. Yes, I'm sure that we should probably all take the opportunity to sort of, after a little, well, actually, we've got, Richard, the opportunity through the effectiveness review to sort of perhaps reflect a little bit, haven't we, on how we feel that's working. So maybe that's we could take that opportunity as part of it. But really good to see the sort of very more insightful, specific things that are being drawn to the attention of the board, whether positive or more challenging. So thank you very much, Judith. So that closes section 8, which is our risk section. We move on then to our strategy section, and section 9. We start with the environmental analysis. It's really an opportunity for particularly Angela, but also other exec colleagues to give us any sort of verbal update that's relevant in relation to what's happening around us, either within the system or nationally, that perhaps isn't covered in our report. So, Angela, anything you want to comment on at this stage?
Yeah, just a few things, Krishni, please. So I spoke about Rob Bridge the Unitary CEO in the North leaving. Just to remind people, he does leave this week. So we have an acting CEO, and that's George Chandler. We've worked with George before, so he's known to us and the county. We've also had a new Director of Public Health appointment in the North, a lady called Jane Bethia, who I think David Williams has worked with before and is coming from Notts Healthcare. So again, we welcome that appointment. Just to highlight to the board that David Sloman, Chief Operating Officer, has requested to visit the Trust in early July, which I think is good, and that builds on the earlier visit that we had from the Prime Minister. So again, we will plan for that. In terms of the East Midlands Alliance, since we last met, I've chaired a meeting of the CEOs and the chairs, and I think it was a very helpful, constructive meeting where we reflected on achievements to date, recognised what had been contributed collectively, and more importantly, there was a real consensus of how do we develop the next phase, which is really encouraging. So Christian and I will be involved in a workshop that we're planning on in early June, and I've managed to get external facilitation for that. So more to come to the board on that. And then finally, just to say that some of us attended the National Innovator Programme in London yesterday. Obviously, we are one of those, just to remind people. It was a good event, others may want to comment, but I just wanted to comment myself on the comment. Steve Powis, the Chief Medical Officer, was there, and he made a comment which I think is important for boards to hear. Firstly, he said that it was really important that people thought about doing the right thing for the population, and secondly, the right thing for the organisation. And I think that illustrates the journey that we're on in population health and how we're going to make a difference through integrated care and the challenge for organisations in that. So I'll leave it there. Thanks, Krishni.
Thank you, Angela. Chris?
Yeah, as people know, I've sort of shifted to focus to support the collaboratives more now. And so I was invited to go with Angela and David and Julie. And I suppose it's to share with the board. I mean, the perspective I had before going to that was obviously these things are developing, they're interesting. But we listened to, as Angela said, David, the CEO of NHSE. And, you know, that's straight from the horse's mouth. He'd been with the minister. And it was very clear, it came out very clearly to me that collaboratives are something they see as the way forward. So if we think about the collaboratives having the money to commission things, how they guide the development of strategy, what they do, there's a lot of talk about the, you know, providers leading about how the ICBs would be involved. So I think I've got a real sense the ICBs are there, but collaboratives are definitely going to become a massive strategic factor in moving forward the agenda. And I think I hadn't immersed in that as fully as I got the chance to do yesterday. And I'm guessing that others might not be as aware of that, having been exposed to it myself. So I think that is quite an important thing for the board to now be thinking, how do we get involved? How do we sort? And potentially, how might we shape things more? And his key message was, you're not going to contract your way out of the problems we've got. You know, it's about collaborating. So they are moving back. Some of us, unfortunately, like me, can remember before purchaser provider splits many years ago, that it's going to be about working together with the, you know, with the KPIs, with measuring what we do, but finding their solutions. And they gave many examples of where things have moved on through that. So I think, you know, it's timely, and it is important for the board, I think, to be aware of and maybe think about how we do that in our development sessions, how we start to understand this, how we think, how we're going to influence it. So I think, having gone through that experience myself, I thought it was really timely to share that with the board.
Thank you, Chris. And I think, you know, that the description, the kind of the way of working and lead provider and collaborative arrangements sort of really fits for me well with the patient story we've just had, and you know what we might want to, if we're genuinely thinking about commissioning for outcomes and changing the way we work. Actually, you know, the story that George shared with us for Danny, actually, for me, is actually one of the kinds of examples that we really need to build on. David.
Thanks, Chris. I thought really helpful, and thanks for your personal reflections. I suppose the bit I thought I'd just add to your point about sort of board understanding and the way of working is to remind ourselves that there are only 9 national innovators, and we're in the mix. We're one of those 9. So we've got a really good opportunity to shape that policy and that way of going forward. And I kind of look at it and go, we're all aware of where those gaps in pathways are. We all kind of get frustrated by them and when they don't deliver stuff. And here's NHSE saying, we'll back you. You can sort them, go away and fix them. So it is a really exciting place for us to be able to take it forward and develop it.
Thank you, David. Okay, Julie?
So I thought I'd just come in and add that actually at the centre of this very much yesterday was the clinical leadership and the importance of clinical leadership in these collaborative. And it was a section, Stephen Paris was there, and it was 2 examples of clinical leadership in some collaborative work. So I think it's really important that as a board we think about our clinical leaders and how they're involved. And I know we're doing some work on that, but it was really powerful about clinical leadership yesterday.
Thank you. Sounds like it was a really productive session. So really valuable to have that opportunity through the scheme and the bid that we made, which was successful. So excellent. Thank you very much, colleagues. So we move on to the reports in this section. So my report, first and foremost, paper F. I really just want to take the opportunity. I know many of you had the chance to meet some of the new governors at our Council of Governors, but just really a warm welcome to a big group of governors. Some of us had the chance to meet, I think Julia, Richard, myself and Joe and Tim actually were there too. We met a number of the new governors face to face, which was really lovely because it was the first time we'd really been able to sort of do that, and we spent more time getting to know each other. And colleagues who weren't able to come, governors who weren't able to join us for that, we met with them yesterday to just go through the induction. And I was really taken by the experience and insight that I think some of our new governors are going to be able to bring, many of whom have had connections and interests and insights into the NHS in different ways. So I just wanted to welcome all those new governors and really look forward to working with them. And Richard Amponza, who is our Deputy Lead Governor, is acting as our Lead Governor now that Chris Davison has stepped down. Richard Smith and I had a conversation about we perhaps need to check what the sort of approach is now to inform NHSE, because we have previously done that when we've had a change in Lead Governor. So we probably just need to conclude that bit of the process, but otherwise it was just to note Richard's acting in this interim capacity as Lead Governor and really welcome the opportunity to work with him on that. We're obviously now beginning to focus on the annual public and members meeting, which will come around in no time in September, I think, isn't it, Richard? So UDIT has offered to work with the governors on that as well, because obviously this is a really important event for the governors. But we've also got a number of webinars that we're putting on, the first of which is actually about the work of carers. And Krishna Yathiraj, who's one of our staff governors, but also consultant psychiatrist who leads Carers Corner, I think is still involved in it, isn't he, Richard? He's going to be leading that webinar for us, along with somebody from a representative from Northamptonshire Carers. We're hoping it'll be Mark, but he may not be able to do that, but certainly working with them. So really encourage everybody really to promote that to staff, to members of the public, to colleagues around the system. And I think actually, Richard, we agreed we would perhaps let Health and Wellbeing Board members know. So we might take the opportunity to do that, because I think we had discussed the importance of the carers role in terms of health and wellbeing. So we've got a number of other things there for colleagues to note about system developments as well, that been great that we've had Ned's involved in all the ICB committees since the start of the year. So that's really positive. And we've got another joint session with KGH coming up, which will focus on the joint forward plan. So really all for you to note, apart from, as I say, welcoming the new governors. What I just wanted to also mention personally was that it was fantastic to be able to go to 2 conferences, face-to-face conferences in the last month or 6 weeks. Had the privilege of closing our leadership compassion conference, and also the nursing and AHP's quality conference, both with a compassion focus, which I think was fantastic. And it was just lovely opportunity to meet so many staff. So really great to see those back on, and really good to be a part of that. So thank you. That's my update. If there are any questions, I'll pause there, but otherwise hand over to Angela for her report.
Thanks, Krishni, and just highlight a few things and add a few others, if I may. So people see the reference to Hewitt review and report. I think it's fair to say it's still work in progress in terms of implications or how that will affect local or national ICSs, but important that we all stay close to that, I think. In relation to the new chair for Kettering and Northampton General Hospitals, just to highlight, this is John MacDonald, who is currently also the chair at University Hospitals of Leicester. So I work with John very regularly already in my role in Leicestershire Partnership Trust. A thank you to Julie, Linda and the team for the Nursing and AHP's conference. I was on leave, but I heard so much about it, and it clearly was a very good conference, in addition to the one that Krishni's already mentioned. So thank you very much. These things are really important, and I know that a lot of work goes on behind the scenes to get them going. So thank you for that. It's really pleasing, and the fact we've had a bit of a community story focus, that we've also been recognised around the remote monitoring work in our community through the Ageing Well programme. And I think that again is an example of how things are moving and shifting. And again, if you haven't seen the NHS providers' recent provider development series on patient flow, both ourselves and LPT as a group are mentioned around our work with virtual wards as a case study. So I think, again, that highlights that particular focus of our community teams. And thank you to the charities. They're fantastic. They support us in so many ways. But the fact that we've got this artwork at Wheatfield is great, because, you know, I'm a real advocate for the artwork that is done within our services, but also the fact that we've got that being recognised and supported, I know will go a long way with teams and with our patients. Similarly, welcome our new governors. Look forward to working with you all. And luckily, Richard and Ponza was also at Berrywood yesterday, so I was able to see him face to face. So it's good to be in the same room with him. And we call everybody a leader here at NHFT, and I think it's really encouraging to see Andrea Goddard, Andrew Raymond, sorry, recognised as Caterer of the Year. It's really great to see all parts of the trust being highlighted and selected, and I think, you know, fantastic to her, and we all know and see that when we operate across the trust, but to get her recognition is I think fantastic. We've also got indication of junior doctor strikes coming up in June, so just to highlight that, I'm sure people are aware, but of course the team will deploy what's needed to manage that situation. We've got the Virtual Wellbeing Festival coming up in July, and we're continuing to support the system with that. So again, it is open to everybody. Please encourage everybody to have a look at what's on offer for that as board members. And the final thing just to mention, one of my roles within the trust is also to be the baby friendly guardian, and I'm pleased to say that we have achieved accreditation once again. Now that's a credit to all of the teams within our 0 to 19 and our clinical leadership in this area. It's fantastic. I was interviewed as part of that process, and it was really very thorough. And I think an example of our teams really rising to excellence. We were encouraged to think about achieving gold in future accreditation. So I just want to say thank you to all of our staff who've been involved in that too. Thank you, Christian.
Thank you, Angela. Any questions or comments in relation to Angela's report? Richard Wheeler?
Hi, thanks. Just to mention a couple of things, sort of broader things related to that. In terms of the pay award, we've had a series of meetings internally to work through the process of implementing the pay award. Now that was agreed by the Staff Council, which we're working through, and we expect that to be paid to staff at the end of June, just to record that. And sorry, I should have mentioned in the environmental update, I was asked and I represented Angela at the opening Brackley Medical Centre and Community Hospital last Saturday, I think it was. So it was a very good event. The weather was good. It was a really big turnout, and it was great to see all of the services there. So lots of positive feedback for the Trust on the steps that it took in terms of bringing that facility to fruition. So I wanted to feed that back.
Thank you very much, Richard, and an important point about, I think, the pay award as well. So thank you for confirming that. Okay, so if there's no further questions or comments, we move on to paper H, which is our delivery plan for our DIGBQ strategy. And there's an update, obviously, in paper H. David?
Thank you, Krishni. So I was just going to highlight 2 points, I suppose, from the paper of the summary of the things that have happened. And the 2 bits I was going to highlight was I thought it was worth taking a moment to reinforce the breadth of work that's happening across all of the strategy and the way of working. And perhaps a simple way to see that is to look at the fact that there are different directorates leading different elements across every single element of DIGBQ. It's not that developing partnership is solely led by me while I hold the lead responsibility for oversight. The delivery is across our teams. Similar as you look at innovate, grow, build, quality, there are different directorates involved in delivering elements of the plan all the way through. And I thought that kind of was a really good way of recognizing how this has become embedded. This is the way that people do work and the progress we've got through here. So there's lots of detail about the progress we've made over Q3s and Q4, so the last financial year, and the summary and the way of working things through. In thinking, how do we do this better? How do we do this more? What else can we bring together? Adrian Hand, who many of us will know as AJ, our Director of Transformation, and Alison Gilmore, our Director of Strategy and Partnerships, have been working together to look at how they can streamline things coming into Transformation Committee, and we can build a more streamlined reporting on the progress we're working, because many of us up in Transformation Committee. And then that'll help us with consistency of message. It helps us with a further understanding of assurance and ways of working. So that goes forward into the new financial year that we're in now. And then we'll bring an update of progress in Q1. We've already signed off in the March board the plan for this current financial year. And then we'll bring an update of progress in the first quarter of this financial year to July's public board meeting. So hopefully that provides an overview for people who've got queries about the detail, how, or anything else. Happy to pick it up, or equally happy to pick up outside the meeting if it's about a specific deliverable.
Okay, Scott.
Yeah, it's just a brief one, David. It's on the back of that comment you've just made about, following up at the July board. I mean, first of all, the content's tremendous, right? And that depth of engagement across the organisation and the depth of shared working really does genuinely come across. So I think it's an important point that you've highlighted, and I just wanted to compliment that. I think part of the challenge is, whilst it's really assuring to see all the detail that's on it, it's almost too much of a depth of detail for us to keep track of at a board level going forward. And I'm interested in that mechanism, really, the point you were talking about bringing it back to board in July. How will we effectively keep keep track of this at a board level, because all of the DEPTA plans are fantastic, but we won't have the opportunity to test and challenge all of those. So any comments in that area would be welcome, please, David.
David, before I get you to respond to that, I think Judith wants to come in as well, and I suspect it might be in the sort of same area, so I just might be useful to get Judith in and then perhaps explore that further. Judith?
Thanks, Krishni. Thanks, David. I do echo what Scott's just said. I thought it was a really fantastic report, and it was really great to see the amount of work that has gone into delivering the strategy. I suppose my challenge was really understanding what the standard is, where we want to be at the end of the 5-year period. So, and I think that we discussed this at another time, and I think you mentioned that there is work ongoing to actually have, if you like, a limit or a KPI or an actual deliverable that we are going to be able to, if you like, track at board level. So I would really welcome having a look at that perhaps in the next time. And the second point I had was, clearly we are working within a system under the ICB or with the ICB. And I was just wondering how it would be possible to actually link some of our DigBQ work and streams of work to the ICB strategy, because clearly, I can make some dots in my mind, but I think it would be really useful to actually call them out. Thank you very much.
Thank you, Judith. So, David, I think there's a sort of more a process format point, but then I think an interesting point about the connection to the ICB, and I suppose potentially to the joint forward plan when it's published. I'm sort of guessing, because trying to piece together the bits of the ICB that are particularly relevant, and I think the joint forward plan might be. So, David, do you want to come in on both of those?
Yep. Yeah, that's fine. Thank you. Thanks all. So a couple of quick bits that probably worth touching through. We've got a DigBQ strategy that we refreshed, I think, last year, which will take us through about 3 or 4 years. So we've got a kind of overall goal and an aim of where we're going, and then the detail that comes into the annual plan. And Scott, I think you're right about how do we track the detail in the public board meeting, and one of those bits about how do we put the additional assurance in has been that conversation about transformation committee, and a way of actually transformation committee understanding progress, knowing where things are going, that moves forward to strategic exec board performance committee, and then we'll come in here. So I think we'll have a think about how we demonstrate the assurance steps that have happened at the time that it gets to here, and a way of working through. The deliverables point, the KPIs element, we're interested in exploring and mapping out, and so I've started some thinking about the work that we're doing. If we take kind of the integrated performance dashboard, and I'll take a short example on, say, recruitment and retention, so vacancy rates and retention levels and things like that. There are kind of key metrics that we're looking at and mapping and thinking about the ways we're going. Growing our staff, we should see the outcomes of the work that we're doing, the work around social value that creates us as a stronger employer and a way of going, having an impact on things like retention rates, vacancy rates, and ways of working stuff through. It becomes an art, I suppose, doesn't it, rather than a science, to say the development of support with the job centre has immediately delivered a 2% reduction in vacancy rates. But I think they're the sorts of examples we'll try and bring out for you to explain how things are working, where things are going. And then on the link to the ICB strategy, absolutely our strategy links very much into the 10 key priorities, the 5-year forward view. One bit I've struggled with just a little bit, we had a little bit of a conversation about perhaps we put a sort of a matrix into the report which links to the 10 ICB strategies, our strategy and a way of working. The reason we've just struggled with it a little bit is you just end up with it being ticked in every single box. So if you take the work we're doing around 0 to 19, making sure that we've got really strong links with primary care, then that's linking into all of the priorities around the best start in life, which is the ICP one. So we'll just keep thinking it through, but there is a real alignment between what we're doing. We might use, and you're right, Judith, that we might use, in joining the dots, we use slightly different names at the moment, but they are all linking in prevention in the ways of working. So I think there's something there about how, as everything settles down with a 5-year joint 5-year forward view, how we link it in, but we're happy to have a look at that and see how we develop it.
Thank you, David. So yeah, I mean, I think, oh, Robin, sorry, I think you wanted to come in as well, Robin.
I mean, David's partly answered what I was going to say. I was just going to draw down into one detailed area, which is the health inequalities one, because there isn't any explicit linkage in the write-up to how this links with the ICB health inequalities strategy and plan. And it would be nice to see them at least linked in some way within this report. But I'm sure you are, and I'm sure there's lots of joined up work there. And again, to reinforce the point that this should be measured in terms some sort of outcomes rather than outputs, so that we can really see what the real changes in healthcare outcomes for people are. And I think a little bit more detail will be helpful. But as I've said in the text, there is brilliant work in here, and I don't want in any way to diminish from that.
Thank you, Robin, and absolutely echo that. I think it gives a real flavour in a relatively short document. I mean, considering it's a huge amount of work that's going on, it's trying to capture all of that. I think it gives a real sense of the sort of things that are being considered and all being taken forward. So there's just something about how do we evidence where we're having an impact, I think is the question, and make those links to the ICB. I think that seems to me the sort of theme of the comments, but really good to see this report and the sort of depth of activity that's been undertaken. Joanne, final comment?
Yeah, thank you very much indeed. So mine is just a question back to David, really, which is on all of the different strands, there's red risks under risk descriptions. Is there anything in particular you want to highlight on those that you wish board to be cognizant of or take action against?
Thanks, Joanne. I think that's really helpful, actually. You've made me think, because I think the bit that we could reflect on from Chris's point earlier about innovator and the view of the world and the way of going forward is to say the key bit we try and balance off as an exec team is the focus on a red risk for resolution today, but also solving it for tomorrow. And so if you take things like workforce or ways of thinking stuff through, we've got some real challenges that are in the here and now. But if we were to just fix the here and now, we'd still be firefighting tomorrow. And so I think one of those bits is about how do we make sure we get the time for both. The value work isn't just about saving some stuff in year, it's about transforming the way we do business in order to make us sustainable going forward. So I think that's the bit I'd say. I wouldn't say, please help, this risk is a problem. I'd say, please help us keep a focus on solving it today, but also planning to make it sustainable tomorrow.
Okay, that's helpful. Thank you.
Thank you very much. So thank you to everyone. I know David presented this, but actually it's a big team effort, isn't it? And it's the wider team here as well, who are not necessarily represented in this room, but you people like AJ and others who've contributed to this. So fantastic work. And there's lots of interesting things that I'd love to follow up, but I think that's more for personal interest, like there was a reference to getting people to bid for innovation, I think, and I was reflecting that I think the acute group did a Dragon's Den, so I was visualizing something like that, which I think could be quite fun and exciting way of engaging people in innovation. But all brilliant work, so thank you everybody for a great report and some important observations, I think, just about linking it, as we've said, and also I think Joe's point just about making sure that we understand what we can do to help or support, and any barriers to progress that's important for the board to note. Thanks very much. So we move on then to the next section on our agenda, which is people. And we've got a number of reports, the first of which are the Race Equality and Disability report. I think we've got colleagues. Yes, I can see Jane. Hi Jane, nice to see you. Have we also got Amelia and Mo present? Yes, I can see Mo. And there's Amelia. Brilliant. So welcome everybody. So we've got, do you want to do each paper in turn, Chris? And then we can invite Amelia and others to comment as well. So we'll do the workforce race equality paper first.
Yeah, I wanted to draw some highlights out from it, and then obviously it'd be great to get some feedback from Mo and Amelia, and maybe David might want to comment as well. You'll see in the paper we've described the RES information and how the report covers all the various metrics. The key definer is that we look at the representation of staff within the trust, which is 18%. It's worth noting that's considerably higher than the local population representation. Overall staff in post, I think a really positive development is that we've increased the number of staff who've joined the organisation. And I think it's quite clear that we're probably an attractive employer to BAME staff. You'll see that the numbers in the Band 5, which is kind of the first qualified grade, has significantly increased, as does the number of BAME staff across the organisation, which again is positive news. We can't confirm we're seen in that light, but it would certainly seem to indicate that. We've also got positive representation increases across the majority of the higher bands, again, which is, I think, is a positive. Moving on to recruitment, this has improved further from where we were last year, and that's been an improvement over a number of years, which I think starts to reflect the good work we've been doing, and now we're actually 0.02 away from the actual sort of expectation that we should be meeting. Having said that, I think whilst we made positive improvements, the whole thing is about how we actually improve the position across the organisation for our ethnic minorities, ethnic and cultural minorities. The disciplinary figures we've reported previously, we had quite a challenge last year, and I think the board, we talked about that previously, where we had a figure of 8.7, which for some very specific reasons. But again, we have moved that down dramatically, such that, as we said, our ethnic and cultural minorities now, we are only just out of the, we're only a short way away from the standard again, 0.18. So I think those are really significant improvements that we've made. The mandatory training, again, is within the standard. Well, on the staff survey, in the people promise, I think generally we've stayed in a good position on all of that. On the staff survey figures, for example, bullying, harassment, however, we have seen deteriorations which are of a concern, and particularly for the managers one, which again, all of this feeds back into that we need to continue with our work and continue to take it forward. However, I think percentage of staff feeling equal opportunities for career progression has increased, and that again is a real positive. Board representation, again, it's very comparable. So I think overall with the RES metrics, we've seen some good improvements. except within the staff survey, which is an area we know of concern. So I think we're seeing progress, but the point is we have a real hunger to really be the best and really see the improvements move to where we want them across the board. And we're working really closely with our Reach network, with Amelia and Mo, and also with the Together Against Racism. We had a really positive workshop this week, and we've got real ambitions there. So it's in a number of areas we're seeing improvements, which are really encouraging because we've had challenges before. There are still areas of deficit which we need to focus on, but we remain in a space where we are fully committed to that and making that move forward. I don't know if it's worth, if you want to open up to Amelia and Mo, Krishni.
Yeah, thank you, Chris. Yeah, so just for colleagues who are relatively new as well, just to introduce, I should have mentioned David Ledger, who's our sort of lead in this area from the HR business partner side, is also here. So welcome, David. But I thought it was really important to hear from Amelia and Mo and kind of get some perspective from you about your thoughts about the results as well. And so over to you if you'd like to make a comment, Amelia and Mo.
Thank you, Chair. Yes, I agree with Chris. There has been lots of improvement, but there's also areas that require improvement. And where I would like to add on to is the area around sort of international recruitment. As you're all aware, that the Trust has embarked on international recruitment for the last 2 years. And certainly there has been concerns raised via the international recruitment team around racial bias and cultural bias, of which it's an area that really does need improvement, because we need to be able to integrate our internationally educated nurses within the services and within the teams. And the area that I found that's really lacking is areas around cultural sensitivity and cultural competence, which I think is a piece of work that needs to be done amongst our managers, for them to be able to help our internationally educated nurses to feel welcome and supported, and disseminate that through their teams as well. Concerns around as well that have been raised around invalidating the experiences of the international nurses as well fall under the whole sort of cultural bias as well. So yeah, there's a piece of work that NHS England is doing at the moment that they've commenced. There's training that's being commenced around cultural sensitivity and cultural competence. I really do hope that this is something that the Trust will consider and take on board to disseminate to our managers to be able to support our ethnic minority nurses who make up part of the International Educated Nurses Group. That's it from me. Mo, did you want to add on anything else?
Yeah, thank you, Amelia. Yeah, I think the numbers are encouraging. We're all making the steps in the right direction. And this week's Together Against Racism workshop, there were some positive steps that the Trust is taking towards that, especially around recruitment, some really exciting work that's happening around there. So really, it's really positive to hear about that. But one of the things I think I appreciate it's a res report and we're looking at the stats and we're looking at numbers, but the numbers actually don't always tell the true story. And one of the things that we always need to look at is context of the data. So for example, the majority of our workforce, especially our frontline workforce, are nurses. So in terms of the bandings they're in and where they could achieve is around possibly a band 7, band 8 is around the more higher bands the nurses would get to as a realistic impression. And those are kind of what we need to do with the numbers is, can we look at it in terms of context around what people's career progression is, how they're actually achieving those higher bands, etc. That's just kind of some of the work that I would like to see, because that would provide us with a lot more context around the numbers.
Thank you, Mo and Amelia. Some really important points. I mean, given everything we're doing on international recruitment, I think, Amelia, you know, what you've said feels really, really important, because it's such a growing area, isn't it? And if then actually we've gone to that, we've gone down that route, but we're not giving or not supporting people in the way that is helpful to them and valuing their skills and experience, that's not not really going to help anybody ultimately in the long term, and the experience of the individuals will not be a positive one. So I do think, I think the point around that is it really important for us to take on, and I guess there's an opportunity to refresh, Chris, our action plans around this. I know we've co-produced some action plans that have been we've been working on, but I'm assuming there's an opportunity to refresh that. And I think Mo's point about sort of the granularity, I suppose, and the context within the bandings is an important one as well. So understanding where we need to focus further. There are some other comments as well that people would like to make, so perhaps we could pick those up and then come back to you, Chris, just to conclude this. Judith.
Thanks, Krishni. Chris, Emilian, maybe thanks ever so much for that. It's actually, my comments all flow on from comments you've all individually made. First of all, absolutely, we do need to celebrate where we have improved our data. And I'm also actually really pleased, and we need to also celebrate that we recognise that there is more work to be done. And the more work to be done than the way I was reading the report is very much around perhaps the growing difference in perception between, and I have to use the tags from the report, which is white and BAME staff, although I do actually object to both those tags. But the difference in perception of lived experience between white and BAME staff. And one of the areas perhaps where this comes out to me, following on from some service visits, is where staff experience bullying from patients and relatives. This data doesn't triangulate well with the actual data that we get via Datix. So clearly, and I know that this is a known issue, but clearly this is an area that we ought to look at and sort of challenge ourselves as to what would be an easy way to for staff to report this data, and perhaps why they're not reporting it to start with. But then the second point arising from that is around the granularity of data. And Mo, thanks for raising that point. It's not helpful, and I know this is the limitations of this type of report for on a national level, but it's not really helpful to have BAME staff. We need to really understand, especially in light of recruiting staff from abroad and having to manage a diverse workforce in a very different way from a less diverse workforce. So having that granularity of the data and understanding where, if you like, the flashpoints are, perhaps which services our flashpoints are in, would be really useful to drive Together Against Racism, forward in a really meaningful way. So thanks for the report, but those would be my my thoughts around it.
Thank you, Julia.
Thank you, Krishni. Yeah, great. Just want to re-echo Judith's comment about a great set of results, but to build on Amelia and Mo's comments. Amelia, you answered my question I'd actually got, which is around cultural competence, and spoke very eloquently about that. Because for me, anybody joining the organisation, their experience of working with us is their immediate manager and their immediate team, mostly. And if we can just get, it is infiltrating all the way down so that absolutely everybody, understands and is talking, the same, in the same way, in the same approach, with the same kindness and compassion that everybody deserves, then, we are going to take great steps. So I'm with you. It's all about how do we raise that awareness and call it out when it's not happening, and help people feel valued. And for Mo, absolutely, I agree with you. I'm a story person, and I read these reports, and you need something to bring it to life. And I think the stories behind this are really important, because you're right, it's hidden in the data, and the areas we need to focus on are all about the stories, because this is all about individual people, isn't it? So thank you for bringing this to life, and absolutely applaud you. And I know through the networks you're going to do a huge amount of work for this. But again, if there are things that we need to focus on as a board, or you think we can support within the networks, etc., then please shout, because it comes from us as leaders to promote this. But actually, how do we help everybody get to the point where we're at a fantastic place, that everybody has a great experience working with us, because then we have brilliant, outstanding care for patients, because that's what it's all about in the end. So thank you very much.
Thank you, Julia. Saqib.
Thank you. Great report. It's great to see that we're making progress. And I think I probably asked the same question last year, and I don't recall what the answer was, but whether it'd be possible to get a view of this of non-patient facing staff, so non-clinical staff, because I think that's where many organisations also have got differences. You know, in the NHS, obviously, there are more BAME staff in often patient-facing roles, but less so in non-patient-facing roles.
Okay, thank you, Saqib. Banu?
Thank you. I completely agree with the points made, and I think as an organization, obviously we are all very keen to improve on what our offer is. I was thinking kind of in terms of most point whether there is almost this encouragement to remind. Say, for example, I'm thinking of the doctors that are coming from abroad. We have a number of clinical fellows who are doing a fantastic job, and kind of within 12 months have been able to move on quite significantly. And in some ways, my kind of, in a way, my thing is the younger bunch are much more clever than me. I mean, it took me about 3-4 years to learn, and they're learning within a year, and they're doing, I mean, as they've come to the same stage. So we have within the medics quite looked at how to read both the support structures at every level with college tutors, clinical tutors, and almost having that one-to-ones. And my request is, if you're aware of any initiatives that are being used elsewhere that we can share, I would really appreciate it, because I speak regularly to the kind of neighboring counties who have had similar programs for clinical fellows, and we kind of learn from each other in terms of what has helped with the induction. But I was also thinking of whether kind of how to mark that career progression, if it is happening or not as it should. And that'll be for me kind of to look at how to measure that metric. Yeah, thank you.
Thank you very much, Banu. Linda?
Thank you, Chair. I just wanted to add on around the report that we've received and work that is being done certainly to improve in areas. So just picking up on what Amelia was talking about with regards to internationally educated colleagues. So within the Northamptonshire system, we now have our own ethnic minority nurses, midwives, AHP reference group that feeds into the regional group, where there are 4 priorities that have been outlined, and this then feeds into the Chief Nursing Officer Strategic Advisory Group. I'm the executive sponsor of that group, and actually we did launch on the 26th of April with good representation from NHFT, KGH, NGH, and we also had colleagues from St. Andrews. And what's of note coming together is that it's good opportunity to share those experiences. So for example, where KGH have really done well in some of their areas of internationally recruiting and embedding internationally educated colleagues, we are learning and working together with them from that. So we're not just looking at ourselves as NHFT, but actually we're looking at ourselves across the system to improve the experiences of our internationally educated colleagues, including medical colleagues, as Banu has just mentioned. So there is a lot of work that we are doing, and we're recognizing and celebrating those areas where we are starting to see the difference. So thank you very much.
Thank you, Linda. I mean, it's really good to hear that there's a system focus around this, because I think it is a shared opportunity, isn't it, for really making a difference in this space. Okay, I mean, there's been an awful lot of comments. I'll come back to Chris shortly, but just a couple of things. I mean, I think Scott has mentioned in the chat that this is the first time where we've seen a real positive improvement. And so it is important to recognise that, because these have been very challenging standards for us to shift, for all of us to shift, and actually it's good to see progress. Interestingly, just as a sort of a bit of insight on the disciplinary one. As Chris said, we had this very poor and unacceptable score in the previous year, and actually that came up at a regional people board and was sort of highlighted as a particular concern that it had been so significantly increased at the time, and David very helpfully connected with the regional head of diversity and inclusion, and also I think somebody from the national team, and the work we'd done I think was shared as part of that to bring that figure back down. And I think, David, there was a suggestion that that might then be developed as a case study to share with others. So I thought that was a really positive thing, because whilst it was unacceptable and we'd obviously acknowledged that, but the efforts were recognised nationally and regionally. And I think the idea of sharing this, because I think what colleagues around systems are struggling with is kind of making sure that the actions we're putting in place are really delivering change, and things that we know work are being shared and made effective. The other thing that's worth perhaps mentioning is I chaired the Regional People Board on Tuesday, and it was confirmed by the regional HR and workforce director that there would be a new analytical tool that allows us now, which will come out through system CPOs, will allow us to analyse the staff survey results by protected characteristic. So I think that's a new tool. I don't think we've ever collectively had access to that. So I think that's a real opportunity to get underneath some of the staff survey results, which I think would be really positive. And also worth saying that the People Board also reflected on the recent Michelle Cox case, which colleagues may be aware of. This was a case of in the Northwest, not in the Midlands region, but it was a case of found to be racial discrimination. And I know that Nina Morgan convened all of the nursing directors around the region to make sure that the learning from that has been shared, and we can drive forward improvement and change. And it was really refreshing to have that kind of analysis of something that's happened, which we all acknowledge and accept can't ever be tolerated, and therefore it was good to see the learning and the commitment to make a difference on that. So just wanted to make those comments because they were important in the context of the sort of regional focus on this agenda. Chris and David, just come back to you to sort of pick up anything that you feel you can take forward in the sort of next steps on this. Yeah. Chris, do you want to come in?
Yes. So I think taking Amelia's point first about the cultural awareness, that is something we are looking at, and I think we will work with the Reach network on that. We've had discussions about, we've been aware of that. So I think that will be an important kind of the development of managers training. I think, as Mo pointed out, in our vision for how we take the recruitment forward and how we engage people in training around that, I think that will raise issues for people in terms of thinking about cultural awareness as well. So again, very aware of that and the need to take it forward. I think Judith's point about staff and patients is significant, and I think it's becoming more significant. And we have got the 6 steps process we introduced, which is helping staff, but I think reviewing that more, how those trends are developing, some of them naturally. And we have liaised with the police before. I think we've got to really solve the problem of how do we actually take action if staff are being exposed to repeated racism. Do we call the police in? Do we get the police to take action earlier? Because I think there is a risk people become accepting of it. The whole issue about people's mental health state and how that plays in. But I do think we need to focus on that. I think on the career development, we do need to look at the figures and be aware of, if you actually look through them, as I said, we clearly are attracting more ethnic minorities. We've grown the Band 5s by 34%. But actually, if you look at the other figures, we have grown the staff in band 6, we've grown the staff in band 7, we've significantly grown the staff in HC. So what we are seeing is more staff coming into the organisation and their representation in the more senior grades increasing. Plus, clearly, we've got stats that say that we've done good work to remove the kind of, you know, the discrepancy in the recruitment process. And I think most encouragingly, we have one of our most significant improvements has been on staff seeing opportunities for career progression, which has increased, I think, by about 8%. So I think we've got some really, you know, story there is developing. That doesn't mean to say we can take our foot off the pedal. We've got to go more, but I think it does suggest to us that if we keep going, we can really start to get to, you know, start to realise the goals and realise the organisation, the experience of our ethnic and cultural minorities really improving and being a good one. And I think with increasing representation, you know, that's just so fundamental. At one point we were worried about not having the representation. I think we've taken that off the risk register. We're getting there, but we've got to make sure that experience is right, which is key in terms of co-production and how we all work together to make that happen. And I don't know if David wants to add anything.
David, anything to add?
I think it's just recognition, isn't it? We're talking about life cycle and experience of colleagues when they work with us, from really key touch points, from recruitment through to how do we respond when things go wrong and people are on the receiving end of abuse and harassment and bullying. And that's the key aspects of what we want to kind of move into and keep the focus on. And I guess just to make colleagues aware, this is all substantive colleagues in the res for this year, but there will be a bank res as well. So we'll have another piece of work to do June time to look at the experience of colleagues who work on our staff bank. So that'll be an interesting piece of analysis as well to be able to share.
Thank you, David. And medical res is separate as well, isn't it? So it's just to be clear who's included within this. Thank you, everybody, for your comments and contributions, and particularly Amelia and Mo. I mean, I think it's really important that we welcome your challenge and that, you know, we work with you to make sure, you know, and with other colleagues in the Reach network to really make sure that everything we do is work that is, as Chris and David said, co-produced with you, and that you are shining a light on areas that you want us to absolutely change. I know everyone in this room is committed to everything, you know, to making sure, actually, you know, the staff experience, we all recognise how important that is in terms of just creating the right environment for people who want to stay and continue, as David said, the life cycle with us, but also what difference it makes to patient care. So absolute commitment from the board, and absolutely welcome your challenge, continued challenge, Amelia and Mo and everybody else, to make sure we go in the right direction to make the difference I know we all want to make on this. We also need to talk about workforce disability, which is the other standard by which we're measured contractually and which we commit to. And we've got Jane here who chairs that network. Lovely to see you again, Jane. Chris, do you want to cover aspects of this, and we'll equally get Jane to comment as well?
Yeah, so again, I think, you know, there's some good news in here, but again, and Jane knows that we are, you know, passionately committed in exactly the same way to improving our experience of our staff, our disabled staff with long-term conditions. I think highlighting the first element, the increase in the reporting from 6 to 7%. I know that's only 1%, but that is really important. And you're further in the report, we went into the detail, and David could describe. We're really putting a lot of emphasis on encouraging people to report this and working with the network to take that forward. And because it doesn't represent what we see in the staff survey, as we know, the staff survey reports much higher numbers. But again, we are a long way ahead of, well, we are proportionately ahead of the whole NHS workforce and what it reports. On the recruitment, we are within the bands of what's expected there. So again, that I think is a positive outcome. And on the capability, formal capability, we haven't had anybody with a disability identified as entering it, so we haven't been able to do the ratio, but I think that's a celebration that we haven't had anybody going into the capability processes, and hopefully, you know, it's data, but representing that we, you know, we are giving the support and taking things forward. When we look at the metrics for the people promise, again, they've increased against a number, but largely remain the same. So we're not getting any major negative elements. And also in the morale and engagement, we've seen increases, which again, I think is positive. We still need to recognise that that's lower than the non-disabled staff. So I mean, that clearly flags to us that we've got more work to do. I think as we go into the other elements of the staff survey, I think particularly key things are disabled staff not feeling the pressure to come to work, that's reduced, and also that the reasonable adjustments has staff feel that that's improving, and that has been an area that Jane and the network has done a huge amount of work with David to take forward and to improve. I think again, we have had some reductions in staff experiencing harassment from members of the public. We have had an increase in the harassment from managers, which mirrors the information we've had from the res staff. So that also, you know, plays into all the things we're talking about, the cultural work we need to do and the cultural sensitivities. Whereas in the other areas, we've largely reduced. So overall, a lot of positive results, but still a lot of work to do. But we do have a lot of work in train to take this forward. And as you've hinted, you said, Krishna, you know, we continue to look at refreshing the WRES and the WDES, and we work closely with the network to take things forward. I mean, we had the purple light week through this year, so we're getting a higher profile as well. So I think there are lots of things that we need to continue to work on, and I believe the board has got the commitment to that. But again, I think we have got indications that we're travelling in the right direction, and I'm sure it'd be helpful if Jane's got comments as well.
Jane.
Yeah, thank you, Krishna. Thank you, Chris. Yeah, I think the last sort of 18 months we've focused partly on the neurodiversity and people that have neurodiverse conditions, or whatever language you want to use. And there's been a few events, and that's raised the profile. Those events have been very, very well attended, the lunch Leadership Matters Lunch and Learns. And as a result, I've had a lot, and I mean a lot, in double figures of managers contacting me, either to provide, asking me how they can provide support, or asking if we can point people in the right direction of things that they could be doing. And it's as though managers are now asking for help rather than the members having to come to me to ask for help, which is really encouraging. Obviously, some things aren't working as well as they should, and I think it's managers don't know what they don't know, and that's possibly where our big push needs to be. I was very pleased to be able to influence some of the new supervision policy that came out. I've put some comments in there to try and ensure that managers ask people about their health, not just their well-being, their health, and is there anything that is causing a difficulty, as well as have they got any disability. And it's that disability word that's causing us the problem, and that's what's reported frequently. It's that disability. So we are looking as a network now, and we've had 2 very engaging meetings over the last fortnight with members to change the name of the network and the scope of the network, and I think that will give us even better results next year. One of the things that seems to be really, really important to people is the reasonable adjustments, and there's still lots of questions coming from members and from managers about what is acceptable. There's 2 focus of areas that I'll be looking at. One is when we have person with a known disability that joins the organisation and they've already got an access to work assessment of needs, how do we put things in place ready for when they start? Because there's something around that. And also trying to unpick why some managers aren't happy with any reasonable adjustment because they feel as though it's setting a precedent. And of course, it isn't setting a precedent, and that is about team attitude. So one of the things we focused on is making sure, number one, people sign up on ESR to say they have a disability, whether they consider it a disability or not. If anything that's causing them difficulties at work, we ask them to tick that box. And also, when it comes to the reasonable adjustments, the person needs to think about the service and the managers really looking at different ways of working and the benefits of a member of staff rather than looking at the negatives. And I do think there's been a change in the last 12 months, really, of attitudes. So I'm pleased with that. And it's showing up. Obviously, it's only 1%, but that's 1%, better 1% up than 1% down on reporting. So I'm pleased with that.
Great, thank you, Jane. And actually, there's one of the things Angela's highlighted is that actually there is some reverse mentoring going on, which is with colleagues from the network that you chair, Jane. And actually, you know, that's always insightful, isn't it? Because people understand more the experience that staff have. That's always insightful and helpful. So some positive things, but obviously a lot of work still to do, which I think you're highlighting. And it's good because it's good to see that the focus on reasonable adjustments has moved that on a little bit, because I think that was something we particularly highlighted previously. So are there any further comments or questions? Chris, do you want to come in?
Yeah, I think just for the board to be aware, I mean, Angela and David have commented on the reverse mentoring. And I think it did very much strongly come out, Jane, didn't it? And it's something for the whole board to consider, I think, is particularly in relation to long-term conditions and disability, is you don't know what you don't know. And I would really think about that. You talk about neurodiverse, or you talk about deaf or a blind member of staff, or whatever it may be. But actually, I think what the reverse mentoring highlighted so clearly was actually understanding what that means to people, what they experience, how they have to deal with it, what they need to change, what they need to explain, what they need to think about. And we don't think about it in that richness. And I think also that for the disability or long terms and conditions, they are, there are many segments of it. It's not, I'm sure we wouldn't all think of it as a block, but it's quite a diverse experience. So understanding that is incredibly powerful. And I think Jane and the team are working on, just as the Reach network have had, thinking how we describe the network, and the approach we take to things like dyslexia, or which aren't seen as disabilities but are in this broad space that we need to support. How do we take all that forward? So there is some really interesting stuff there. I think what's positive is we're getting that out in the open and talking about it. We will need to think how we change that and move it forward.
Thank you, Chris. And that there's dyslexia, there's long-term mental health conditions. People might not think to describe that as a disability, but it is potentially. So it is just sort of encouraging people to think more broadly. And as I'm on your distribution list, I've seen the correspondence from Jane asking people to think about that. So that's helpful. Julie.
So I've obviously got an interest in neurodiversity, being dyslexic myself. And I have been talking to Jane and others, and I think it's really interesting. We say we've got a 1% increase. A lot of people in the group we're thinking about don't actually see themselves as disabled. And I always go back to somebody I used to work with who was wheelchair mobile. And I talked quite a lot to her about where she saw her disability. And what she actually said to me was, it's society that disables me. I don't see myself as disabled. And I think that is part of the challenge, to get people to actually, you know, tick that box to say they're disabled, because actually they don't see themselves as disabled. It's society that disables them. So I think it is really important that we do change the name of the network. And I don't know if that will increase, you know, reporting, but actually we do need to think about why people don't report, and it's probably because they don't actually see themselves as disabled.
Yeah, thank you, Julie. It does strike me, I mean, ultimately, you know, this is for all of us about, certainly for where it comes to staff, about creating a compassionate and inclusive culture, because actually being compassionate to every member of staff would allow us to be inclusive and would allow us to be able to understand people's different needs and work to accommodate those needs, because ultimately that would get the best out of them and ensure we get the best care for patients, which is what we're all here to do. So I think it links really strongly to our compassion commitment, our you know, compassion champions, and all the other things that we've been talking about when we talk about compassion. Jane, do you want to make a final comment?
Yeah, just very, very briefly, as Julie said, it is the disabled word that is causing a difficulty. And the way we've sort of approached it with the members is that there are health problems, which could be long-term or short-term. They could be physical health, could be mental health, could be neurodiverse. And that's why we're thinking that we need to change, not the, I don't know what you call it, but the inclusivity of the network. So you could have somebody that is menopausal and it's a short-term thing that affects their ability to do their job, but it's still something that things that can be put in place, or experiences, and it's those shared experiences that help. So what we're looking at is the subgroups where people can talk to each other and empathise, but come up with ideas of how they can do things and different examples of reasonable adjustments. But everything comes under an umbrella of the network. So we've had suggestions of the Enable network and also the Ability network. So it is in consultation with the members. They're looking at different things, looking at lanyards, because one of the things that members have really brought up is hidden disability. Now, somebody that is dyslexic, they don't like the word disability, so it's what do we put on a lanyard? But some of the members want, I have a hidden disability, please be patient. So there's lots and lots of suggestions, lots of engagement, and the engagement levels have really increased, and we've got some very, very active members, which is why I think things are improving.
Excellent. Jane, thank you very much for those insights. I think that's been really helpful to sort of bring that to life for us. And I think, Chris, I'm sure as we discussed with the RES report, this will be taken forward in co-production with the network in the way that we've talked about. So are we happy to conclude that there? Is that okay, Chris? You're happy to?
Thank you for everybody's contributions.
Great, brilliant, thank you. So really important progress to recognise in both of those areas, but as ever, more work to do. But really good to see the sort of improvements in reasonable adjustment, or people's feelings about reasonable adjustments and career progression, particularly. I'm conscious we're somewhat behind time, but I do feel like you deserve a break. So I suggest we take till 11:45. That gives us a little bit of time to grab a refreshing cup of tea or coffee, and we'll then need to be prompt to conclude the rest of our business. So see you shortly. Thank you again, Jane and David. Okay, welcome back, everybody. So we'll crack on with the rest of our agenda. So we're moving into the quality section now. We've got a number of reports, so the first of which is from Julia, I think. Yes, as on the assurance report or alert, advice and assurance report, we'll probably need to make sure that we give enough time, Julia and Linda, for questions. So perhaps focus on the really key points you want to highlight on your reports, and then we'll pause for comments and questions. So first of all, Julia.
Thanks, Krishni. Thank you. So you'll see this is in the new format again, and very open to any feedback. There's quite a lot of detail in here, which we felt would give a rich understanding of the very detailed scrutiny we give to quality and safety across the organisation. So I'll take it as read. A couple of things around alerts for the board. One you'll see is around a recent Inspectorate of Prisons report for HMP Whitemoor, and we were assured that the remedial actions are being looked at, and we heard a whole raft of information about the governance around this service particularly, which again gave us some additional assurance. And just to assure you, us as board, that further focus will continue going forward. So that was really important to just note that. We have raised the issue. We did have the end of year performance report for our staff flu and COVID campaign, and it wasn't where we wanted to be, obviously, with lower numbers. However, lots of challenges and lots of issues with data, and lots of issues that were not in our own control, but we've got learning from this, taking it forward for next year, and we were assured that planning is starting for the next year's campaign later this winter. I'll take the advised section as read. There were a couple of things just to pull out. One was the Guardian of Safe Working report. For people that don't know that, that's around our junior doctors, around their supporting them with their working hours and their training. And we do really well on this mostly. And we've had great survey results in the past where they feel really well supported. But due to a lot of challenges and pressures, there had been a number of breaches and subsequent fines. We wanted just to explore that in a little bit more detail for some extra assurance, but the author wasn't actually available. So we will take that forward to the next meeting, just so that we can bring you back some more assurance that everything's been done that you'd expect. In the assure section, just to highlight the annual medical appraisal compliance report, we bring that to board. That's appended to this report. And again, the author wasn't available for comments, but we were assured that the actions from last year have been followed up, and it's there for your information. Risks. We've mentioned several of the risks. We fully scrutinised the quality and safety risks allocated to us, and we mentioned particularly B4, which is the data issue with timely and accurate data. And from our point of view, it was around quality and safety of clinical information, and Julie, as chief nurse, gave us an update around a planned thematic review of System 1 data, our clinical system, excuse me, which we really welcomed and will really help our assurance around that risk. And then lastly, I have to mention the outstanding section. It does give us an opportunity to really focus on the huge amount of outstanding work that's going on, particularly around engagement. So the first 2 points in that section are all about engagement, both through a carers strategy workshops and through engaging families when there's been a patient safety incident. Really, really important pieces of work. The St Andrews contract has come to an end, and wanted to highlight all the collaborative working around that. And then finally, the draft quality account was received. Hugely important piece of work. If people don't know, this is equivalent to our financial accounts, and it's a piece of statute, and it's a very easy to read, hugely uplifting piece of work, where we do look at all the work around quality for patients and our services. So one thing we do need to just double check, I think Julie's going to mention about sign off for this. If you could just do that, Julie, that'd be great.
Yes, so as Julie highlighted, it is a statutory piece of work we do need to do, and in the past it was always linked to the trust annual finances and our annual report. It was split. This will be, I think, the 3rd year it's been split from memory, and we don't have to get this in till the end of June now. So we have a different time frame, so it doesn't form part of the ISA 260. But what we would like to do, because we're still working with feedback from stakeholders, the draft is now being finalised as that stakeholder feedback comes in. We would like to ask for delegated authority to the Quality and Safety Committee at the end of June to sign off the final version, which will actually have to be submitted. I think it's either that day or the following day, because we have to submit it by the end of June. In fact, it goes onto our website and it's a link that goes across unless they've changed it from last year. But I know the governance team will be on this. So that's what I would like to ask board, please.
Thanks, Julie. And one last thing, if I may, before we open it up, just we've planned our 3 workshops for the year, which I know are really valued by all those that attend. And we've actually held the first one since writing the report, and it focused on partnerships. But just wanted to highlight, we talked a lot about collaboratives. As Angela has mentioned before, we talked about population health inequalities, and we had some brilliant folk attend. One lady from the Northamptonshire Black Communities Together group and our own NHFT Equalities lead as a project manager, and we felt we really explored all those areas. And the whole point of doing it is so that when we move forward looking at quality and safety issues within our own organisation, it sets the context so that we look through a lens in the population that we're delivering care to. So I think some great things came out of it, and we're hoping to really make a difference going forward. So that was a really good first workshop. Happy for any comments, questions, etc.
Great, thank you very much, Julia. Robin?
I was just going to endorse what Julie's just said about the value of the workshop that was held about partnerships, which I thought was absolutely excellent. And it really does reinforce the real commitment of execs to working with partners in a multitude of sectors. It was the voluntary sector that's primarily represented at that one, but it was a really good illustration of the commitment of the team to engage in really effective joint work. So I'd endorse that.
Thank you very much, Robin. That's really good to hear from both of you. So any other comments or questions? I mean, I just wanted to, I noted in Julia's report, which, as Scott mentions, is very sort of, for people who haven't attended the committee, is very insightful, and I think that's always a really helpful perspective to observe when you're reading a report. And the vaccination issue we've highlighted, but I think I noticed, Julie, I couldn't help noticing when I was at the quality conference, I'm fairly sure the occupational health team, I saw them escaping at one point when I was arriving. So I wondered if they'd been there, because I think one of the things we'd done previously when we were trying to drive vaccination rates was kind of have like a pop-up vaccination approach, didn't we, at our conferences? So I don't know if I got that right, but I did observe them being there, so I did wonder if that's going to help us going forward again. Oh, Julie, you're on mute.
Sorry, Chair. They were there with the compassion thing, because it's the wrong time of the year for. I'd love to put it through the nursing conference, but it's too early in the year for the nursing conference. As you know, we link the nursing conference to Florence Nightingale's birthday. That's why it's in May.
Okay. So, but it is the important point was the conferences and the practicality, because that had been always a really good thing, or a good way in which we'd achieved compliance, I think, or at least improved our performance previously. That's great. And I think also we just should note the annual medical appraisal compliance report. I think it's really important for the board to note that, because that is a submission, I think, nationally, if I understand that correctly. Banu, is there anything you want to comment on that respect?
Yeah, thank you. I was going to bring it back to the next Q&S committee so that we can present the updated version. We have been able to rectify the software problem, and we're around just over the 90% mark. But obviously, I will present the full kind of AOA for the next meeting.
Great, Barney. That's helpful, actually, because you do highlight, I think, on the first page that a system issue had prevented the sort of data to being completed accurately. So that's great and good to know. Thank you very much. So thank you for that report, Julia. So Linda, then first of your reports is patient safety, paper L.
Thank you, Chair. I'll take it that the report has been read. Just to provide some assurance to the board, the issues that are contained within this report will have gone through our patient safety committee. The committee met last week, and this committee also provides reports into quality and safety committee. We've included there the top 5 themes around our patient safety incidents, providing further assurance on how the trust deals and manages any patient safety incidents with prioritization for maintaining safety, which means although the incident will then go through our process of reviewing it, is it a serious incident, concise incident that then requires further investigation or not, immediate steps are then taken to ensure that learning is immediately picked out from there, and if any remedial actions need to be put in place, those are done before the investigation actually commences. We continue to ensure that when we've had incidents, there's duty of candor, so that is that openness and transparency to those involved is maintained. We've provided an update with regards to thematic reviews that are currently taking place, and the areas that I'd like the board to note further within this report is to be assured that as a patient safety team, we continue to review incidents for learning. We continue to ensure that we are being honest and open in any incident that occurs. We've also put in place remedial processes to mitigate any organizational risk or risks that are associated with any of our investigations that have not yet been assigned, noting that we've had a massive reduction in unsigned investigations, and that will change. It's because those are being assigned and allocated as we speak. So not the same situation that we were in earlier this year. It's also to note that whilst all this has been going on, our areas are busy, but certainly this is an area that is being focused on, with a lot of the reports coming through being quality assured and signed off in the April to May period. So I'm happy to take any comments or questions. Julie might want to come in if there's anything else you want to add.
Thank you, Linda. So I think Linda's brought our attention to the key things she wants us to take from the report, but fundamentally it's obviously there to assure us about the processes that are in place to scrutinise and respond to serious incidents and yeah, incidents of harm. Robin.
Yeah, I attended this meeting in lieu of Julia while she was off, and I'd like to offer a degree of assurance to the board that the meeting considered a huge range of additional detail about the review of the various issues that have been highlighted by Linda, and I was given real assurance that all of these issues are under full review and are achieving the proper degree of candour as has been raised, and are being properly dealt with. It was an enormously informative and helpful meeting, and this is only a very small summary of the high quality of the work that was being done there.
Thank you, Robin. That's really helpful. Thank you for sharing that. I just wanted to make a very brief comment that I particularly noted on the page relating to self-harm, that the incident data relating to self-harm in CAMHS inpatient areas continues to demonstrate a reduction. I wanted to highlight that this had been a priority for governors, and we had in fact had a presentation, I think, from, I think it was Judith and Sakiba actually jointly covered self-harm and the reduction that had been achieved. So I just thought it was important to highlight that, because obviously governors had shown an interest in that, and it's really good to see that reduction. And the other, just to not for discussion particularly, but just to mention, obviously the work going on patient safety strategy, and the potential for introduction of patient safety partners. I couldn't help myself and had a quick look at the framework because I was interested as to what opportunity there might be for governors to get involved in that. The framework was really clear that it's not actually the same as the governor role, and that the governor role is separate, but there is potentially an opportunity to consider governors to be patient safety partners as a separate, particularly governors who obviously have experience and insights that they can bring to bear. So I just thought it was worth noting that, and probably something for us to consider as part of this implementation, albeit recognising that the role is quite separate from being a governor itself. I wondered if we could just give that some thought in consideration, Julie, with Richard. But thank you very much. Really helpful to get all the assurance that we've had from Robin, and also the points that Linda brought to our attention. So we move on next then to the Monitoring Workforce Safeguards Annual Review, Paper M.
Thanks, Krishni. Robin had his hand up again. I wasn't sure if you wanted to mention anything before I started.
I was only going to quote a single statistic related to self-harm as you raised it, Krishni, which was that there had actually been a 50% reduction in self-harm incidents reported within CAMS services as a result of new ways of working. So there was real progress in this area. I was just going to cite that, which actually doesn't appear in the data that's been put forward to this committee, although it did go to Patient Safety Committee. So it's a real area of improvement.
Yeah, thank you, Robin. Apologies, I thought that was the hand from earlier. So thank you. Linda, back to you.
Thank you very much, Chair. Again, I will take it that the report has been read, and to start out by just providing some assurance to Trust Board. The monitoring of workforce safeguards, we do report here retrospectively. However, as an organization, this information is looked at in other groups and more so on a weekly basis. We certainly do triangulate when we've had incidents through our weekly early warning signs. Is this linked to any workforce issues? We also have an internal workforce safeguards board that then reports into Quality and Safety Committee, and again, further looking at this information. We know that through the groups that our Director of HR leads, again, workforce is one of the areas of focus, so certainly looked at in different arenas. This particular report is with regards to the focus on patient safety, and we need to remember that we absolutely value our workforce, and workforce continues to be a challenge, not just for NHFT, but nationally. In this reporting period, we have commenced our establishment review meetings. This is where we use the national accredited tools to look at our safer staffing, particularly looking at nursing workforce, and we look at the support workers or healthcare assistants who support nursing. So we've had the meetings take place in March and April. Information has been analyzed, and the next step to this is to look at our confirm and challenge, where we start to understand a little bit more around the application of clinical judgment, around understanding those areas where there's less occupancy or the increased acuity that comes with the reporting of these tools. So that's the place where we are now, and we should be able to report on that at the next Trust Board. We've highlighted within the report risks that are being reported. Most of the risks will be risks that have already previously been reported, but one of note is with regards to our temporary staffing and the ongoing work around the staff who have come across to us at HMP, Peterborough and Bedford areas. So a lot of work has been going on with our colleagues in temporary staffing, other managers behind the scenes, our ops colleagues, just to ensure that we are moving people across onto our NHFT bank, as well as using our own trust-approved agency. So a lot of work has gone that, just to commend the bank manager, Katie, and her team, because they've been really supportive in that. We've highlighted areas within this report around the improvement we need to make with regards to some of our training. So one of the areas that we have had low compliance is with our Safeguarding Adults Level 3 training. So prior to coming into this meeting, I confirmed where we were with that, and the staff that are trained are now up to 51%, where previously we had been reporting 16%, 22%. We have a trajectory in place to achieve 85% compliance. So we're looking at those numbers, bookings this week and next week to get us over that so that we cover even the slippage. So a lot of work being done behind the scenes to improve that. Huge thanks to Anne and Ops colleagues with regards to our rapid tranquilization training. This was another area that we were working on and put additional recovery plans into that. And we're just at compliance with it, but still other staff who are requiring that training. So the last bit really is to ask the board to note the risks, the mitigations that we have included within that, and for the board to be assured that we are effectively managing our workforce safeguards. We are reviewing where our fill rates have been below that 90% or exceeding that 120%, and that this continues to be an area of focus for the organization. Thank you, Chair.
Thank you, Linda. Very comprehensive. Any comments or questions? Linda, I just wanted to comment on something very briefly. I mean, not for a huge discussion, but perhaps we could just take this away to either enhance it for next time. It's just on page 22 of the report, the home enteral feeding team, and I know I'm sure we've discussed this before as a risk, but I was just a little bit concerned that the wording of the report says, you know, that the caseload numbers are now at unsafe levels, but there are no mitigations reported against that. And I do feel that that's important that we address that, because that sort of, you know, I think for anyone reading that implies that we're not managing it. I'm sure we are, but I'd like to see that evidenced in the report. So if I could leave you to have a look at that and follow that up, I think that would be helpful. Otherwise, I think we're happy to take the assurance from the report. Really good to see the establishment reviews in progress. So excellent, thank you. We then have paper N and paper O, which are about complaints. Obviously, we've got the Q4 report and the annual report. Could we take those together, Linda, if that's okay, just so that we sort of focus on complaints and maybe if there's anything particularly to highlight from Q4, that's okay. But I guess the annual review is the most important thing to take in, because that gets published, if I remember correctly. So over to you on that, Linda.
Yeah, just to provide some assurance, Chair, that this information will have gone through to our complaints review committee that continues to meet with subsequent updates that come into Quality Forum, which meets monthly, and then also a report that goes into Quality and Safety Committee. So within Q4, it was just to note that there has been some activity insofar as our friends and family test performance, which is again detailed within our annual report. So just looking at the positive feedback that we've received, being 90.5% overall, we noted that we've also received what would class as negative feedback, which is an opportunity to improve. And actually a lot of this is then reviewed with our involvees and strengthens our emphasis on co-production. So certainly we are utilizing that feedback. I'll talk to our annual complaints report. It's continued to be really busy for the team. We've seen a lot of complaints that have been investigated, where the complainants have come back, asked us to revisit, relook at it, and we've done that with an emphasis of ensuring that we've done our best to actually respond to the issues that the complainants would have raised. We've detailed within the report any of those cases that have gone to further review with our ombudsmen, Parliamentary Health Ombudsman, local government ombudsman. And what's important, certainly for NHFT, is the learning that we derive from this and actually what we put in practice going forward. A lot of work has been done insofar as our actions that we take forward, and certainly we've seen a real improvement in proactivity from especially our operational services, insofar as a lot more local resolution being done so that we're reducing issues escalating to complaints. Massive, massive thank you to all those who are involved in local resolution, because this isn't just, it's not just at service level, but we also have director level colleagues who are meeting with patients, their carers, again, to assist in that process of resolving things locally. We've included some examples within the report of how we have learned from these issues. We've also included in the report how we will take forward actions and prioritize for the forthcoming year. Certainly, we've presented this report to assure the board that we are managing our complaints, PALs, and working with our feedback in line with guidance that we've received from NHSE. We continue to review and challenge ourselves around that. And certainly we've done some work around our complaints and feedback with LPT, just so that we are sharing learning and working together. I'm happy to take any comments, questions. Thank you, Chair.
Thank you again, Linda. And I was going to invite you in, Scott, because I think you were at Complaints Review Committee and you'd already helpfully given us our feedback, some feedback, but it'd be great to hear from you, Scott.
Yeah, certainly, Kirsty. I'm aware we're up against it for time. I'll keep it brief, okay? But yeah, I mean, I was fortunate enough to attend the Complaints Review Committee earlier in the month. Not an activity area that I would normally support, because I'm usually looking more at performance and financial aspects. Didn't really know what to expect, to be absolutely honest. But my reaction to that was that, and I want to put this in the context of providing assurance to board, I was extremely impressed by a combination of both a sympathetic approach on behalf of the members of staff that are carrying out the investigations, but an incredibly forensic approach as well. Just relentless in the desire to make sure that they were doing the complaint justice and going through it thoroughly. And then from there, that the commitment they took to cascade the lessons learned from it across the rest of the trust and across the system, and that came across absolutely in spades. And I think just to highlight that further as well, just my personal experience is also brought out by Linda in the annual report as well, where she references those elements as well in the complaints handling activity. So for me, I actually found it going to a complaints committee, I didn't expect to be describing it as a surprisingly uplifting experience, but it was, genuinely. So thank you, Linda. It was really great.
That's really good. Thank you, Scott. Always good to get those fresh insights and perspectives. So thank you, Linda, for all those reports and for that comprehensive update on the various quality aspects. Really important focus, we know, for all of us, because obviously, within that, it's all about keeping our patients safe and providing the kind of quality experience that we want to for our patients. And there's always more work to do, but we thank everybody for their efforts in and focus in these really important areas. Okay, we move on then to finance and performance. We first of all have two assurance reports from Audit Committee and Performance Committee, and then we have the integrated organisational report. So Saqib, anything you particularly want to bring to our attention?
So in the interest of time, I'll just call out the report that we've highlighted, anti-crime service progress report, that there had been misclaiming of allowances over an extended period of time, and we're trying to ensure that obviously that learnings are made that doesn't happen again. The other thing just to highlight was that the limited assurance report that's under advise, that will be reviewed on the 8th of June, so we'll give an update at the appropriate time. And involving payments, which isn't on this report, but that is being looked at by Richard, which will be hopefully closed down by the next meeting that we have. And finally, I just want to thank the finance team. That obviously this is a very busy time for them with audit, and obviously they're quietly behind the scenes making sure that our audits are completed on time and that we have our annual accounts are submitted on time. So I just wanted to thank that team, along with all the directors that support that.
Thank you, Saqib. Really important. It is always a incredibly busy time behind the scenes, isn't it? And having just started the new year to be sort of trying to sign off the old one. So thank you, Saqib, for observing that. Any questions for Saqib from relation to the audit report? No, thank you. We'll note that and note the alerts and advice that's also been highlighted. Over to Judith then for the first time, I think, on the Performance Committee, if I'm right. Judith, anything to highlight on your paper?
Thanks, Krishni. Yes, I just want to very quickly highlight a few areas, focusing on the advice firstly. Clearly, the system priorities for this year and the operational plan are ongoing, and there are, unknown unknowns from a risk point of view, but the committee was certainly assured that they are being managed and that there's going to be ongoing governance around that and reporting via the Performance Committee. And also another advice item was in relation to the only very recent appointment of the ICS Digital Director role, which meant that the system digital transformation strategy has been somewhat in abeyance, let's put it that way. So there is some delay in relation to the digital transformation as a system. The committee received a wealth of assurance in the number of items that are highlighted in the report. The risks that we looked at were specifically the ones where there's been a change in the residual score change, which we have already discussed or will be discussing in the Integrated Assurance Committee, so I won't spend any time on that. But we did look very carefully at the risks around the current year's financial plan and value programme, and will continue to do so in the coming months. In the three items that I'd like to mention and spend a little bit of time on is in relation to those, but we really did need to celebrate the outstanding. Firstly and foremostly, a real sincere congratulations to Richard and his team for really achieving the end of year results, the outcome. Obviously that's subject to external audit, but it's been a super challenging environment last financial year. Secondly, the integrated organisational report, which we are yet to come to in the agenda, but an absolutely fantastic report from Dave and his team, which we really enjoyed reading and discussing, and we will look forward to receiving in the future and seeing further development on it. And finally, the digital maturity assessment that NHFT has had to submit to NHSE. Absolutely fantastic score of 3.3 out of a possible 5, which has brought us in to be second in the country as compared with similar trusts. So that's really fantastic news in relation to our own digital maturity. A slight damper on that was that our system only scored 1.5, which is one of the lowest performing systems in the country. So clearly we do have some work ahead of us in supporting the system, but nevertheless our own is really something to celebrate. And I shall leave it at that for questions and comments. Thank you.
Thank you, Judith. Really helpful. And as we said before, really good to see that section on outstanding items and things to celebrate as well. Any questions or comments? I think the only thing I particularly wanted to pick up, because I think we are being asked, if I'm right, Richard, to endorse the terms of reference for Performance Committee, because some changes have been made to that. And I had one observation. I'm perfectly happy with the changes that have been made. I just wondered what, and this might have to be something Richard would take away, and I'm addressing this to Richard Smith. I'm just conscious that I've asked our 2 new associate directors to attend that meeting, and I wasn't sure whether associate non-executive directors, whether that in some way needs to be represented. So Richard, it was just something, it's a bit of a technicality, but just something I thought we might want to reflect on. But aside from that, our colleagues are happy to endorse the terms of reference, because I think the board does need to endorse that, but we'll take away that point to clarify. And David has just mentioned in the text chat that there was a system-wide exec meeting, and System Digital, indeed I was present for the afternoon of that. System Digital was key to transformation and was identified and agreed as an absolutely key priority. So great, thank you very much. Very helpful report again. If there are no comments and questions, we'll move on to the integrated organisational report, which the Performance Committee had very much welcomed, and really good to see the new format. So, Dave.
Thanks, Krishni, and thanks, Judith, for those gracious comments. I know the team will appreciate it. It is their work. Just to draw your eye to a few things, you can see this is beginning to come together now as something which gives us a lens to look at all the domains within the trust. Well, certainly four domains initially, and we'll bring in a fifth one later this year. There are some gaps which you'll also notice, so that's work in progress in terms of the SPC methodology. The exec summary on page 212 of the pack I'm using gives you a sense of where we are trust-wide. So you can see our performance gathered under assurance in terms of pass, hit and miss, and fail. And I'll talk a bit about those in a second. And then for those that we don't have an SPC rating, they're RAG rated on the right-hand side. So you can then see where we are green, amber, and red in relation to some of our workforce metrics and so on, which I know Chris has covered some of that. In terms of worry lists, ADHD continues to be a concern for us locally. We've got a set of workshops coming up to look at that and alternatives to what we might offer to people on those pathways, because the waiting list does get longer for that, and we are seeing that replicated nationally. So I know there's discussions happening with RC Psych, and other organisations are getting involved. You'll have also seen the news with private provision around diagnosis, but then the bulk of the care needs then are moved on to NHS providers. So there's some work happening nationally looking at what a shared care model for some of those private providers might look like, so that they actually have to do some of the aftercare for the individuals that they diagnose, and thus kind of be responsible for that component. On MSK, we are seeing a bit of a dip in the numbers waiting, which is hugely positive, and we're seeing a good proportion of people within an acceptable time frame. Today also there's a report from the Chartered Society of Physiotherapists highlighting the impact on rehab, considering how chock-a-block hospitals are currently, where people don't have the physical space to actually be able to be mobilised and supported to move back to an independent recovery state. So we're addressing that through our recovery independence beds and the work that Anne's leading on the pathway to with our community hospitals. But it's something to bear in mind, I think, as we go into winter and spaces in hospitals become increasingly pressured. It does have an impact on outcomes, particularly rehabilitation outcomes. So apart from that, Krishni, I mean, the report, recognising time, the report kind of, for as much as it is there now, speaks for itself. I hope people find the framework useful, and when it's complete, I think it'll help us compress some of the other reports, because some of the data in here you'll have seen in Linda's, we might be able to bring things down into one, so we get one lens, and then there's a more shorter narratives from other committees supporting the wider organisational reporting framework.
Thank you, Dave. Julia.
Thanks, Krishni. Yeah, just to reiterate, fantastic report. It is so good to see it come together. It's going to be so much easier to triangulate information. And again, complete credit to your team, Dave, for all the hard work. I know what goes on behind it, but it is incredible. It really is a fantastic piece of work. So I know it's evolving, but really, really good. Thank you. Just to add one piece of assurance, Dave mentioned around the ADHD services, and both for adults and children, of course, we have a focus on that in performance, but also through the quality committee. committee as well. And in our report, I skipped over it, but we did talk about the harm impact that we monitor going forward around people who are having to wait such a long time. And those harm reviews will continue to seek assurance on that. So just an additional sort of angle. Thanks. And of course, we brought that up with governors actually a very short while ago, and gave a presentation to them. So that will be useful. We'll go back to them as and when we receive further assurance. Thanks.
Thank you, Julia. It is a really important area, isn't it? I think it's receiving increasing NHSE focus as well, actually. It's certainly been raised at various QSRMs, I think, the ADHD and autism waiting lists, and of course it's a huge focus for the CQC and was an area of improvement. I do remember the teams coming to present to us. I know some colleagues will be won't have been part of that, but I do remember both teams, the children's team and the adult team, coming to present to us and talk to us about some of the challenges. So it's good, good to hear the continued focus in that area. Joe.
Thank you, David. As you know, a relative newcomer, I just want to echo everyone else's thanks for the format of this report. My personal favourite was the bit at the end where you explained what all the letters meant. So thank you ever so much for that. That glossary was just priceless. My question is maybe a bit of a naive one, but in terms of the pressure points in our system as we see it, our patients and how our communities are responding, do we get this information back into the broader system so that we can see where the overlaps are with other service providers' experience? Because, when we think about things like, if we pick up ADHD as the topic of the moment, there will be third sector agencies and children's services at the councils, all of whom have a role to play in this. And it would be quite nice to make sure that we get triangulation from all providers' perspectives.
Sorry, Krishni, go ahead.
No, I was just going to bring Anne put her hand up, so I was imagining Anne probably wanted to respond as well. But Dave, you go ahead and I'll bring Anne in as well.
Thanks for the feedback, Joe. Increasingly, yes. I sit on the, with Judith, sit on the delivery and performance group, and it is easier in that format to look at the whole pathway. So where we provide bits of pathways and local authorities provide another bit of the pathway in terms of discharge or reablement, and we've got elective services on the other side. So that is becoming a lot more transparent, and I think when it hits its groove, it hasn't by any stretch of its imagination found its full form and function, but I think that's certainly what it's intended to do. And we'll probably come in on the ASD, ADHD piece in terms of how we can support people while they're waiting for a diagnosis, because we should follow what the needs are, and the diagnosis doesn't necessarily tell us what the needs are. The needs are what they are. So we try and use as much resources available to us to support people with that. The REACH collaborative that we saw previously is a good example. But Anne, I'll bring you in on that, please.
Yeah, I was just going to say, I also sit now on the operational delivery group at the ICB, where we're looking at operationally what the challenges are relating to the data that we have, and I think that's starting to come together. But I think we've got a way to go, because that's a reasonably new set of meetings. I think where the richness comes in that multi-agency is around the collaborative, and the workshop that Dave noted earlier in particular. Is bringing service users, carers, GPs, voluntary sector, ourselves in a room to say, actually, this is a real challenge. It's a national challenge. Nobody has got the perfect answer. What we need to do is to walk through the pathways and understand where those pressure points are and what could we imagine differently as a community. And I think that's really important, because we do the reviews on people waiting. And that will absolutely continue. But I think it's, we're using a lot of activity to do that when you want to try and prevent having to get to that stage. So how do we get that really careful balance of protecting and looking at clinical reviews where we are now, but how do we move into a space where we're not having people waiting for actually quite a small service? when it's impacting communities, families, and lots of services. So how could we do that slightly differently with our voluntary sector, etc.? So I think there's rich discussion that happens in other forums that is very much around the community and not purely individual organisations.
Okay, thanks, Anne.
Thank you, Anne, and thank you, David. I mean, I think, you know, those problem solving together is ultimately what we should all be doing through the integrated care approach, and then of course, you know, through our engagement and attendance at these various new committees that we're all now beginning to engage in different ways, I think will be also helpful in terms of assurance. Julie.
Very quickly, I was just looking at page 213 in my pack, and I just wanted to be a bit clear around our supervision compliance, because it's reported there as 30%. Well, in fact, it's a quarterly target. We measure in quarters, not months, and I just think it would be really helpful in future to have a bit of a rider on this one, or a bit of narrative, because it doesn't align with everything else. 30% is pretty low, isn't it, against our target? So we would expect it low in April because it's the first month in the quarter. So I just think we need to be mindful of how we're reporting that one, please.
Yeah, noted. I think, Julie, thank you. Helpful. David, if we can leave that for you to pick up with the team, that would be good. Great. Well, thank you very much. I think everyone's welcomed the new style of report. Really welcome the development. Gives us a really good insight, obviously scrutinised as in performance as well. I know Dave needs to go now because you're attending a Health and Wellbeing Board, so thank you very much, Dave. We just conclude then with the assurance section. We have the provider licence, the annual governance statement, and the LPT and NHFT group chairs report. So paper 5, Chris, sorry, paper S.
Yeah, so thank you, Christine. So the report provides assurance to the board that the trust is compliant with the conditions of the NHS provider licence. We no longer have to submit this, but we do need to undertake the assessment. And it's the board's asked to consider the self-certification in relation to compliance and subject to board approval. So ask for board approval, signatures of the chair and chief exec will be added. So I take it as read, and obviously that's the decision that we're asking the board to take. And if there's any questions, Richard or myself, I think we'll aim to clarify them.
Okay, thank you very much. So any questions or comments? It is a requirement for us, but as Chris said, we don't submit it, but we do need to complete it. Okay, is the board happy to sign that off then? Okay, thank you very much. Richard, I just noticed that the recording or transmission seems to have stopped, so I'll just make that bring that to your attention, because it shouldn't have stopped yet, I think. Annual governance statement then, Chris, paper T.
So I think this is a very similar vein, Christian. The governance statement sets out the systems of internal control we use and disclose any significant control issues that we've got. We provide a draft to the board, and it's asked to receive assurance on the AGS, and then ask you to receive it and to identify any areas which it requires further assurance at this stage in the development of the document, which will go into the annual report. Richard has developed this, I've been through it, and Angela's seen it as well. So obviously we'd all recommend it to the board, but if there's any questions or changes, again, Richard and myself would be happy to respond.
And it's also been through audit committee, I think, previously. Yeah. So to be clear about that, it's had some previous scrutiny. Julie?
I've already discussed this, Richard, so you already know there's a tweaking to do in the workforce safeguard section, but Richard and me are on that. I've spoken to him about it already this morning.
Okay, and the final version of this, I think, as Richard, I think Richard will come to our ISA meeting, won't it, soon, whenever the date of
June,
it is.
middle of June.
Yeah. So obviously the final sign off on this is not today, but it's there for you to make any further suggestions if needed. Joanne.
Thank you. Accepting that I'm really late to the party on this one, my only comment would be when reading through this, what I didn't see was the external environment reflected particularly strongly in the AGS. You know, we've seen an example just about our digital health relative to the digital health of the system. A lot of our transformation activity relies upon that digital platform working equally across the system, and I just think some of those types of risks, those sorts of environmental risks which come out of a system, might be reflected in something like this. And so I realise that I've not been around long enough to input into it, but that would just be my initial reaction.
So yeah, sorry, Chris, do you want to respond to that?
I think Richard, Richard, I'm sure will come in, but it is very much focused on our internal controls. But Richard, do you want to come in?
Thanks, Chris. Yeah, really good point, Joe. I think what I would say is, of course, we're somewhat constrained by a template that we're provided with to fill in, which sort of frames what we put in. But I think we'll certainly take that on board in relation to the final version. It could be that we can include some more references to system working, which of course will become a focus of the coming year's report with the new duties. So thanks for that. We'll take that on board.
And I think, just to acknowledge, Chris, yes, I know AGSs are intended to be internal focus, but our internal efficiency is driven in a system environment now. So I think it's important we acknowledge it.
Yeah, I think it's a good point you make.
Thank you,
Joanne, because it, as Richard's saying, I think we do reflect quite a lot on this about how we can improve the richness of the report, and I think your point is helpful in allowing us both to take that away and think about it.
Thank you, Joe. So that's something we can perhaps reflect on before it comes to, I don't know whether it's worth Richard sort of circulating changes before we get to the ISA meeting, and that allows us to reflect further on kind of comments people have made. Okay, other than that, I think we are we're not actually, as I said, we're not actually signing it off, are we? We're just considering it today. So so it's just there, and there is an opportunity, I think, to review that again before we do that. So thank you for that. And then finally, we have Paper U, which is the highlight report from our last joint working group between LPT and NHFT. Just to mention that myself and Julia represent NHFT in that group, and then obviously other execs will be involved, as well as Ned and Chair from LPT. So David, was there anything you wanted to particularly bring to our attention on that?
I thought I'd just very briefly say two things. I guess to remind everybody, the purpose around the joint working group is looking at the things that we can do that add value to both organisations by doing them once. So again, the highlight report is summarising some of the sort of strategic ways of working together against racism, the social value charter, things we've talked on before. And I think the other bit that I wanted to flag is we'd all recognise as public service organisations, if we can deliver greater value for money by doing some things together, it's got to be a focus of the work that we're doing. So there's a real focus on saying we've all got value programs to deliver at the moment. How do we lever out the best that we possibly can from that? And I think that those sorts of topics get picked up in the highlight report.
And David, do you want to say anything about the group university hospital status? Because that's an appendix to that report.
Yes, fine, thank you. So really interested in saying and working with the universities and saying there's an opportunity for us to do something different and to champion research, innovation and a way of working, which is really good for service users and patients, because if we could do more research around mental health and community services, we've got the ability to improve the way we work and the way we develop. But it also could add value to our retention rates for staff. It could open up portfolio careers for people for the way of working. And then it starts to formulate a greater and stronger partnership with all of our universities, all of our ways of working. So we've been exploring something with the University of Leicester, as a way of working, but that would open our ways up to all of the other universities and the work we wanted to do. So what we're looking at the moment then is how could we use the group name to signify and develop all of the importance of the group university status, and working towards that development of adding in the university status into the university bit into our name change and branding. And therefore that helps to reinforce the way we're working and the way that we go forward. So we're asking for support, aren't we?
Yeah. So just to be clear, I think this isn't the, where other trusts have got University Hospital in their name. That's quite a significant step to take. This is just an initial opportunity we have as a group to demonstrate our commitment, I think, to the group University Hospital principle, and then we can do further development. And I think we've talked about this actually in one of our joint development workshops as well. So it's really asking for broad support for the principle of this and development of this to the next stage. I think that's right, isn't it?
Correct. And you are also correct that University Hospital teaching status would take a number of years to achieve. That does mean something different to a starting level at the moment.
So everyone happy to support this? It certainly was formally endorsed in the joint working group, but obviously it is a board, but it is important that the board supports it. So thank you. So I think, David, you didn't need anything else from us today, did you? So
No.
More to note the conversations that have taken place, but note that also the board is supportive of that direction of travel around the groups. Group development around University Hospital. So we will build on that. We have now come to the end of our formal items. I apologise that we've run late. I shall take responsibility for that. But I think we have covered quite an extensive range of things today, and really thank all colleagues for their contributions and all the work that goes into producing the reports and the content for these boards, which shouldn't be underestimated. We have got some items to note, paper B and W, which are our register of interests and hospitality. I will take it there are no other items of business. So apart from running a little bit late, which, as I said, was probably because of the richness of the conversation, was there anything else that we wanted to reflect on in terms of the snapshot review of our discussions today? If there is, I'll welcome that. Otherwise, I'll close the meeting. No, nothing particularly to comment on.
Are we going to, sorry, just a quick one. Are we going to start on time at 1 for the private board?
I was going to suggest that we still start at 1:15 because I think we have got enough time, if that's okay with everyone, unless everyone, I just would like to, for the well-being of the board, I'd like to give you a proper break, I think. Yes, please. So I would suggest we start at 1:15 for the private board, and we have a good break now. But thank you everyone, and thank you to members of the public and governors who've observed the meeting. Thank you.
Thank you.
Thank you. Bye.